Vedanta. And to his credit, he has various international and national publications. He did his DM from prestigious Shri Chitra Institute from Trivandrum. He is executive member of Indian Epilepsy Society. He is on editorial board of International Journal of Epilepsy. And he has been teaching to many people whom I know personally. And he is a terrific teacher. So now we go to sparks in brain. So now we are dealing with reduced flow to brain. Now comes role of electric disturbances in the brain, sparking in brain. So master himself, over to Dr. Atmaram.
Thank you, sir. Thank you for giving this opportunity. Epilepsy is something which almost each and every doctor deals in their practice, whether it's a physician, pediatrician, emergency doctor. So this particular topic is very important for practically each and every doctor. So, as you know that it's not something new. Epilepsy was there from very beginning. Even it has been mentioned in our Vedic era also, in like an apsmaram, it's a Sanskrit word for epilepsy. So, when we talk today about approach to epilepsy, we try to discuss how to differentiate whether it is an epilepsy or not. If it is epilepsy, what type of epilepsy? What syndrome we are dealing with, what are some various age-related syndromes, and then what kind of investigation or workup we need to do for patients with epilepsy. So, first and most common question for MBBS levels is what is seizure and what is epilepsy? What is the difference? So, seizure is just an event. The patient you see in emergency having convulsion is a seizure. It's an event. But if somebody is having recurrent seizures, then it becomes epilepsy. So there are various steps in the diagnosis of epilepsy by International League Against Epilepsy. The first step is whether it is epilepsy or not. Second step, if it is epilepsy, whether it is focal seizure or generalized seizure. Then try to make a syndromic diagnosis. Why it is important? Because we need to plan long term. Giving medication in emergency is okay, you can give any anti-epileptic drug, but from long term point of view, what drug we need to give, what dose we need to give, how many years we need to give will depend upon the type of epilepsy, the syndrome of epilepsy. Then any particular etiology, like people having genetic epilepsies, structural epilepsy like post-stroke seizures, post-head injury seizures, post-encephalitis seizures, and then associated issues. So it's not only important to know that the person is having epilepsy, but also whether some other issues are there, like headache, depression, anxiety. So these are some of the very, very common comorbidities, obesity. So why they are important? Because the drug which we choose should not worsen the comorbidity. So the first step is definitely trying to make a proper diagnosis. We should not miss the diagnosis. So what happens, especially in pediatric population, small kids, they have funny abnormal movements which are quite often misdiagnosed as seizure, especially if there is a doubt and you send for EEG, which is commonly read by not an expert and reported as abnormal. And because of these two mistakes, wrong history and then wrong EEG report, the person gets anti-epileptic drugs for 2-3 years, which was not required. So it's very, very important to not miss the diagnosis. There are many mimics of epilepsy depending upon age, especially pediatric population. The small kid can have breath holding spells which may mimic like seizure, then can have some infantile syncope. In elderly, we may have something like TIA which can present like that, stroke-Adams syndromes. In adult population, even at times migraine can mimic like a seizure. Movement disorders, sleep disorders like parasomnia, these can also mimic like seizure. So how to differentiate? The commonest differential of epilepsy is syncope. So one is the situation in which it happens. An elderly gentleman getting up in the night, going to washroom and falling in the washroom is the commonest presentation of syncope. Anybody having viral fever, high grade fever because of perfusion, sweating and all can very commonly have syncope. It's not uncommon to see school assembly and kids falling in the assembly in sunlight because of syncope. So these are some of the common triggers of syncope. Commonly happens in standing with dehydration, with fever, if somebody taking diuretic in elderly population, getting up suddenly from sleep. The usually duration is few seconds. They will immediately become conscious, will not have any prolonged event, will not have any prolonged confusion. Incontinence is quite common in syncope. So presence of incontinence should not take you away from syncope. Even double incontinence can happen. Patient can have urine incontinence as well as stool incontinence. In fact, stool incontinence is more common in syncope than in seizure. Then other features like cold extremities, profuse sweating, these will also favor syncope. The other differentiation is from the pseudo seizures, non-epileptic seizures. Nowadays we use the term non-epileptic events. We don't label it as pseudo seizure because the pseudo word is slightly not very technical. So the differentiation is usually the non-epileptic events are prolonged events lasting 5 minutes, 10 minutes, 15 minutes, and the semiology will vary. In some of the events they may have tight posturing, tightness, jerking. In some they may just lie loose. Commonest differentiating feature is the usually non-epileptic event the person will keep eyes closed, while in epileptic event the person keeps eyes open. The duration of a typical true seizure is 1 to 2 minutes. Post-ictal confusion can happen for 5-10 minutes to half an hour, but the tonic-clonic movements, the jerking will not last for more than 1 or 2 minutes. So this is how we differentiate from true seizures. I'll show you a video. So in this patient, the patient is keeping eyes closed. You can see the movements. They are very random movements. Sometimes keeping hand on the stomach, otherwise only left sided movements. You can see these eye closure. So the differentiating point is the tonic-clonic seizures are definitely have different kind of frequency, and eye closure will not happen, and those kind of movement usually last for 1 or 2 minutes. In this patient it was for almost 10 minutes. And after that you can see that patient is again keeping eyes closed and not responding. So this can also happen for half an hour to 1 hour in patients with non-epileptic events. So some of the differentials that we discussed: syncope, psychogenic events, sleep disorders, parasomnias. So patient who is sleeping and an abnormal dream can suddenly shout and can be restless. Then movement disorders like paroxysmal dyskinesia. This is an entity which is commonly missed. The person will come with, like he is sitting in the class, and when he gets up from the prolonged sitting, there is sudden posturing of one side lasting for few seconds without any unconsciousness. And that event happens only when he is getting up from a prolonged sitting. So this is the classical presentation of paroxysmal kinesogenic dyskinesias. Then hypoglycemia, hyperglycemia, electrolyte imbalance can also produce drowsiness, which may at times mimic like a seizure. So suppose you know that yes, it was a clear-cut seizure. Then what should be the next step? Next step is to rule out that we are not missing any provoked cause or the etiologies which are treatable. So first seizure can be provoked one. The commonest provoking factor can be hypoglycemia, can be hyponatremia. In patients with alcohol intoxication, drug intoxication, sleep deprivation can trigger, and alcohol withdrawal or any drug withdrawal can trigger seizures. So these are some of the triggers where you may not need an anti-epileptic drug if everything otherwise is normal. So the chances of recurrence of the after first seizure are quite significant. Almost 40-50% people can have recurrence, and we need to know what are those patients who are likely to have high risk of recurrence. But there are certain patients where the risk is almost negligible and we don't need to start anti-epileptic drugs. One is febrile seizures. As you know that this classical febrile seizure starts at around 6 months of age to 5-6 years of age. Withdrawal seizures, hypoglycemia, hypocalcemia, other electrolyte imbalance. Then drug related seizures, syncope or any acute concussion related seizure. Seizures happening within 1 week of events like stroke, like trauma or like encephalitis may not require anti-epileptic drugs for a longer period. Another term is reflex epilepsy. So what is reflex epilepsy? It happens when their seizures are provoked by particular trigger. One of the commonest trigger is eating epilepsy. Whenever the patient starts eating, he starts having confusional state and a seizure. Other common triggers are reading epilepsy, photosensitive epilepsies, even calculation related epilepsy, mental arithmetic epilepsies, musicogenic epilepsies, hot water epilepsies. These are few of the triggers. Olfactory epilepsies triggered by particular type of smell. So at Sri Chitra, I have seen practically almost all those varieties, including olfactory epilepsy having one particular soap smell triggering seizures. And at my place I had seen this calculation related epilepsy where a person starts calculating mathematical work and gets seizures. So this particular video is to show you eating epilepsy. The patient is from Nepal, and whenever he starts, not always, almost, but seizures are triggered only during eating. So out of 10 times eating, he may have seizures only once or twice. So the family knows that he can have a seizure, so they started recording before he started eating. And now you can see he is confused. You can see his right hand is postured. He is not moving his right hand. He is a bit jittery, not responding, stopped taking meal. Though in this case eyes are closed, but it's again a very brief event and classically triggered by, now he can say that he is coming out, and now he is better now and stable. So this is one of the example of eating epilepsy. Then the point of acute symptomatic seizures, like in patient with stroke, patient with trauma, hypoxia, surgery, SDH, any other infection, may have seizure within 1 week of those events, and those comes under the category of acute symptomatic seizure. For those category of patient, you may not need medication for a long period. The risk in these scenario is very less compared to the patient who have unprovoked seizures, or the seizures are happening after 1 week of these events. A patient with head injury, stroke or encephalitis getting seizures after 1 week, those patients are very highly likely to get seizures, and in those patients you may have to give anti-epileptic medications even for lifelong in some of the cases. So what are the risk factors of recurrence, or the patient who are likely to have another episode after 1 episode? Symptomatic etiology means like same, head injury, encephalitis, stroke. Patient with lower IQ, it indicates that brain has significant brain damage, and these people are likely to have seizure. Hemiparesis, any deficits, any abnormality on MRI like even brain tumors or any structural pathology by birth, abnormalities in the brain, heterotropias, cortical disc malformations. pediatric patients are less likely to have recurrence than adult onset seizures. If somebody is getting seizure at the age of 30, 40, 50, 60, then those people are very highly likely to have another seizure. Then EEG abnormality, but the problem with the EEG abnormality is of quality. So it should be from a reasonably good quality lab, otherwise just borderline EEG should not be taken into consideration. Age of focal epilepsies, multiple type of seizures, past history of febrile seizures, multiple episodes happening frequently, history of status, history of failure even on medication, these patients are likely to have recurrence. So this is another video. Basically this video is to show you how to take history in a patient with epilepsy. This particular patient is telling his own story. बताइए आपको कब से दौरा आना स्टार्ट हुआ होगा लगभग?
करीब मैं 4th या 5th क्लास में होऊंगा
जी।
और दौरा नहीं आता था पहले, जैसे मैं चाय पी रहा हूँ या कुछ खा रहा हूँ या कंघी कर रहा हूँ जी, तो एकदम झटका लगता था। ओके। मतलब पूरा चाय गिर गई या यूनिफॉर्म को छुपा हुआ आके जी, अपना मतलब किसी को बताया नहीं जी। और उसके बाद करीब 10th क्लास में मैं होऊंगा जब फर्स्ट टाइम मेरे को हुआ था जी। और 10th क्लास में जब मैं सुबह 4 बजे उठा, बेल बजी तो मैं गेट खोलने के लिए गया जी, तो वहीं पे ही मतलब कंप्लीट जो फिट हुआ।
सो द फर्स्ट पार्ट ऑफ द हिस्ट्री सेज कि कभी जब मैं कुछ करता था एकदम हाथ में झटके लगते थे और सामान गिर जाता था। सो दिस इज क्लासिकल ऑफ मायोक्लोनिक जर्क्स. This is myoclonic epilepsy, and then patient had a big seizure. That big seizure happened when he got up quite early at 4 a.m. So sleep deprivation related seizures early morning, then history of myoclonic jerks. So this patient is having classical juvenile myoclonic epilepsy. So this for this detail you don't need any investigation. The moment you know this history, you know that this patient is likely to have juvenile myoclonic epilepsy. So this is how you differentiate whether it is focal epilepsy or generalized epilepsy. In patient with focal onset seizures, the symptoms may be like automatism. Automatism means some rhythmic movements like chewing movement, lip smacking movement, rubbing of hands. So these are some of the classical automatic symptoms which are seen in temporal lobe epilepsies. Then generalized seizures, as we mentioned, myoclonic jerks, then GTCS. Then some of the seizures like epileptic spasms which happen in pediatric population, in infants, that infantile spasm or slam spells what we learn in pediatric patients, sudden kind of posturing of hands with like a salam. So these are infantile spasms. So these comes in unknown onset of epilepsies. But when we know focal versus generalized, we should also know what type of syndrome we are dealing with. So when we talk about syndrome, we need to know about the etiology. So among the etiology, the commonest is structural, where there is some structural abnormality in the MRI, which can be some hypoxia related, perinatal insult. The commonest cause of occipital lobe epilepsy in India is when a baby is born and the care is not good, and delayed in cry or not obstructive care is not properly given. In those cases, the patient can have hypoxic brain damage, or the next day if the blood sugar is low, hypoglycemic damage can cause seizures in the later life. Other structural cause we have discussed like encephalitis related, trauma related, stroke related, tumor related, or brain malformation related. Genetic like tuberous sclerosis, as you know, neurofibromatosis. So these are some of the syndromes, Sturge-Weber syndromes. Infections like herpes encephalitis can cause seizures. Metabolic, as we discussed. Nowadays, another very important part of epilepsy is immune or autoimmune epilepsies. So some of the syndromes like NMDA encephalitis or LGI1 encephalitis, these are a different type of autoimmune epilepsies. I think tomorrow we have a talk on autoimmune epilepsies. And then almost 1/3 of the patient, we may not be able to find the cause. Your MRI can be absolutely normal, the EEG can be absolutely normal, still patient may have epilepsy. So when we talk about epilepsy syndromes as per age, so these are some of the issues in relation to age. The commonest age group in terms of epilepsy is starting in teenage and then in the middle age. So these are some of the syndromes which have been mentioned as per age, like benign familial neonatal convulsions, neonatal seizures, myoclonic epilepsies. The term benign Rolandic epilepsy, nowadays we don't use the term, but it means that they are benign, the seizures last only for 2-3 years, and patient may not need medications. Occipital lobe epilepsies, then childhood absence epilepsies. As you know, this childhood absence epilepsy starts in school going age group, and the kid will have blank episode lasting for few seconds, 10 seconds, 20 seconds, which may be 10 to 100 times in a day. And the best way to diagnose absence epilepsy is ask the child to hyperventilate, and if the child is hyperventilating, he will become unresponsive, which can be confirmed by EEG, and it's a relatively benign condition, and most of the kids grow out of it, and within 1 or 2 years the epilepsy disappears. But in some of the patient it can evolve into juvenile myoclonic epilepsies, or in between term is juvenile absence epilepsy. So these are some of the syndrome. I am not going into detail of these, like familial neonatal epilepsies, autonomic seizures, which is also known as Panatopolis syndrome, if somebody wants to know, occipital epilepsies, and then other things like mesial temporal lobe epilepsy and hippocampal sclerosis we will discuss when we will talk about epilepsy surgery. So these we have discussed like childhood absence, juvenile absence. Then some of the patient with absence can also have myoclonias, so a myoclonia with absence epilepsies. Then these are a bit of worst type of epilepsies, or prognosis wise very bad epilepsies, like Dravet syndromes, infantile encephalopathies, ESWS, that is epilepsy spikes during slow wave of sleep, then progressive myoclonic epilepsies, which are very fatal. There can be gelastic seizures. So gelastic seizures means the patient will have laughing episodes, unprovoked laughing, multiple times in a day. That becomes very, very embarrassing for the family, and these seizures are commonly associated with hypothalamic hamartomas. So there are self-limiting epilepsies, there are encephalopathies, which are very bad type of epilepsies. Then nowadays we do have genetic epilepsies, genetic studies being done commonly in epilepsy in patients, especially in pediatric population, where there are epilepsies not getting controlled with medication, and we do test blood test for genetic studies, and various genes are found, and depending upon that particular genes, then medications are modified. Like in this particular glutar 1 deficiency, you need to give ketogenic diet. In other, like sodium channel abnormalities, you need to avoid particular type of medications. So that's why genetic studies are important. So other genetic epilepsies, as we discussed, childhood absence, juvenile myoclonic epilepsies. In some of these patients, you may have only GTCS without any myoclonus. Then patients may develop encephalopathy, especially with the patient with the myoclonus or myoclonic epilepsies. So these encephalopathy patient will have developmental abnormality. The child may be normal till 4-5 years of age or so, and then start deteriorating. So cognitive retardation or deterioration is a significant factor and should be evaluated in detail, and many of these patients may be reversible, especially in patients who have CSWS pattern. In EEG, during sleep, if they show continuous spikes, and if you treat with steroids and other medication, the child may have very good improvement. So other syndromes like Rasmussen's encephalitis, then sleep-related hyperkinetic epilepsy, especially frontal lobe epilepsies. So next part is about etiological diagnosis. We have already covered most of these part. Then the last part of diagnosis is comorbidities. So why comorbidities are important? Because many of the patients with epilepsy have other issues like headache, anxiety, depression. Some patient may even have psychosis or bipolar disorder, but that is very, very less. Most of the patient only have a mild kind of anxiety. Some of the patient can have superadded depression. Non-epileptic events may be there in patient with epilepsy also. So this combination of true seizure and non-epileptic seizure is very, very dangerous and very, very difficult to treat. So what kind of investigation you need when you are treating a patient of epilepsy? Again, the most important part is detailed history. If you have not taken history, no investigation can compensate it. So history, as Dr. Piyush mentioned in patient with stroke, same thing is there with epilepsy. You need to have detailed history before going for investigations. What happens if you have not taken history and you have sent the patient for EEG, and many a times the EEG is reported as abnormal despite being normal, and then again the double mistakes, not taking history properly, relying on EEG and treating the patient can be very, very dangerous. So we need to have detailed history, analysis of symptoms, then other things like EEG, MRI, and then psychological assessment, and may need some blood tests. So among the analysis of semiology, the seizures have three parts. Aura, which is before the seizure start, the patient may feel something before the seizure. Then ictus, that means during the event what is happening, and then post-ictally, whether patient after the seizure was conscious, whether confused or something else. In some of the patient may have weakness on one side after the seizure, known as post-ictal palsy or Todd's palsy. The semiology will depend upon which part of the brain is involved. If suppose the motor area is involved, then patient will have clonic jerks. Patient, the temporal lobe is involved, especially the neocortex, then patient may have auditory hallucinations. Occipital lobe, patient may have visual symptoms. The parietal lobe involvement may have sensory symptoms. So these are some of the symptoms which are related to particular type of the brain part involved. So when we analyze history as a semiology, we try to find out which side of the brain is involved, right side or left side. So these are some of the symptoms which can help us in labeling whether it is from the right side or left side. So if it is coming that one side automatism is there, the patient is rubbing hand kind of movement or rubbing the chest or anything like an abnormal movement from one side of the body, one hand. So usually it happens from the same side of the brain. While if it is kind of postured, some tightening is happening, that is on the opposite side of the brain. Then some of the patient wipe their nose after the seizures, then again it is on the same side. Other comes like, are we dealing with the dominant hemisphere or non-dominant hemisphere? So as you know that majority of us are right-handed, and that means our left side of the brain is dominant brain. So if the seizures are starting from left side of the brain, the patient will not be able to speak. There will be an aphasia. For a long period, patient will have speech arrest. While in non-dominant, patient will be able to speak. The speaking may be very, very irrelevant, but some words will be there. Other than that, patient may have a bit of symptoms like autonomic symptoms, bladder related symptoms, speech, smile, spitting, these kind of symptoms. So last part about semiology analysis is to differentiate between temporal lobe versus other part of the brain. Why the temporal lobe is given significance over frontal, occipital and parietal is, temporal lobe is the most common lobe for epilepsy origin, and temporal lobe epilepsy can be drug resistant and may need surgery. So the commonest aura in temporal lobe epilepsy is some kind of fear, some kind of epigastric sensation, something is coming up in the stomach, butterfly kind of sensation. So these are some symptoms in temporal lobe epilepsy. Then patient will not have much of jerking, body tightness or anything, will just have some automatic movements, lip smacking, chewing, hand rubbing, these kind of movements. While in other lobes there will be clear-cut jerking and posturing. And temporal lobe epilepsy seizure frequencies are not very frequent. Mostly they are once in a month to once in a week, while frontal lobe epilepsies and other seizures may be very, very frequent. It may happen 2-3 times in a day also. So once we have analyzed the seizure semiology, we try to find out whether it was a generalized seizure or a focal seizure. If it was a focal, from right side or left side, then if it is from right side or left, then temporal versus extratemporal. So this much we try to dig out from the history. Investigation wise, MRI is very, very important tool, and we should have a good quality MRI. A routine brain MRI may not be a good choice in patient with epilepsy. We should do epilepsy protocol MRI, because in epilepsy protocol MRI there are high resolution images and the cuts are taken at very, very thin slices are seen. So these are some of the standards for the epilepsy protocol MRI. Lastly, EEG. So I will not discuss much about it, but only I want to say is that whenever the EEG is done, the technician should be well trained, because if the technician is not trained, the quality of recording will be very poor, and then reporting definitely is going to suffer. And a sleep recording is very, very important part of EEG, because awake record you can miss 80% of the diagnosis. Video EEG is another investigation which is required in selected cases when we are not able to diagnose what type of epilepsy we are dealing with, whether it was a true seizure or a non-epileptic event, it is a focal seizure or generalized seizure, if it is focal, from which part of the brain is it coming. So in video EEG we admit the patient, we do round the clock video and EEG monitoring. It may take 2-3 days to 1 week to get the event, and this is mainly required in patient where the diagnostic dilemma, or in the patient when we are considering for epilepsy surgery. Other investigations like metabolic workup and genetic workup we have covered. Thank you.
Very nice and excellent coverage. So we have so far from hypoperfusion to brain, that stroke, we have discussed approach of that, from sparking to in brain, that is epilepsy. So approach to epilepsy we have discussed. So before Dr. Atmaram ventures into drug treatment of epilepsy or refractory epilepsy or status epilepticus, maybe a couple of hours later, let's go back to our initial stroke approach. So now we go to therapeutics of stroke. So before for this therapeutics, Justin, where is Justin? Oh yeah. So so first of all, for stroke therapeutics, Dr. Justin, who has done his DM from SGPGI, he is a stroke neurologist, many publications to his credit, and he is a fellow in neurointervention also. So he'll be setting the turf with the pharmacological treatment of stroke. Before the master comes in, Dr. Gaurav, and talks about interventional management. So Dr. Justin, if you can come here. And meanwhile, in between, if there are any questions or queries, you can just set up your laptop. So, Dr. Atmaram, just do a mic. So,
hello. Yes, sir.
yeah. So till he sets up his laptop, I would like to ask you, what is your recommendation for drug treatment? Let's say if somebody has a scar in brain because of stroke or because of head injury or because of a surgery. So how long the scar would remain lifelong? So how long you would continue treatment?
Actually, most of the guidelines says that if somebody is having head injury or something, some scar, and she just starts later on means after a week, after a year or so, in those patients, there is already a well-established network in the brain which is causing seizure. So ideally, we should offer lifelong treatment.
True. If anybody else has any Further questions to ask from Dr. Atmaram or from Dr. Piyush? You are please most welcome, as I said in the beginning. Yes, sir. You have something.
Sir, I had one patient, my close relative, abroad. She had COVID. Following that, she had suffered from stroke posterior circulation. Later on, she developed epilepsy, status epileptic. During treatment, she developed skin rashes. She was on triple drugs. So probably dilantin was the one of the culprit. Now, what should be the ultimate course?
So when we talk about drug-related rashes in epilepsy, so there are 3-4 drugs which can cause rashes: phenytoin, carbamazepine, oxcarbazepine, and lamotrigine. So these are the 4 drugs which commonly cause rashes. Levetiracetam cause rash rarely, but it can also cause. Other drugs don't cause most of the times. So in patient with rash, then these 4 drugs we will have to avoid. We can use any other options like levetiracetam. Nowadays even breveracetam is there. Then lacosamide is there because he is having focal epilepsy. In focal epilepsy, we will talk about in the next talk what are the drugs which are good for focal epilepsies.
Yes, sir.
Sir, single seizure, not require any pharmaceutical intervention. Then we have to wait for the second seizure. And risk in between two, how will cover?
Sir, nowadays even the ILA definition wise, even after first seizure, in some selected cases you may have to treat. Like in this patient, the video I showed, the patient had myoclonic jerks. So if the patient had single seizure, we will have to treat. Patient had stroke in the past, now present with single seizure, we will have to treat. Yes, sir. Even stroke patient can present with grand mal seizures. So if MRI is absolutely normal, EEG is absolutely normal, patient had no past history of seizures, then you can wait for the second seizure. If patient had any trigger in the past, then we will have to treat.
Any further questions?
We have 4-5 patients of autoimmune encephalitis in our ward. So during admission, they have intractable seizures, and we gave around 4 to 5 anti-epileptic drugs. So what should we do in future for tapering these drugs, sir?
So autoimmune epilepsies are very notorious because they don't respond to anti-seizure medication. They have good response to steroids or IVIG. So you need to be very aggressive on immunomodulators and immunosuppressants and give a time, at least 1 month, 3 months, 6 months to things that get settled. Then start tapering one by one.
We can taper.
We can taper, definitely we can taper.
No further questions, then we can take it up later. Okay, ma'am. Yeah.
Torsades with seizures. Torsades with seizures. So was it the seizure that was causing torsades, or the torsades was causing the seizure?
I couldn't understand. Acha, okay. So at times it's difficult to differentiate cardiac arrhythmias and seizures because seizure can cause arrhythmia and arrhythmia can cause seizure. So best way to do is video EEG. Record the event with the ECG monitoring and see what is one is. See, you will have to treat the first the life-threatening condition, which is VT. So treat arrhythmias. For the time being, give anti-seizure medication also. And then once the thing settles, then you try to differentiate.
So let's move on to pharmacological treatment of stroke. Dr. Justin.
Good morning all. Welcome to Udaipur. Today my topic assigned to me is pharmacological treatment. I will be mainly dealing with IV thrombolysis in stroke. So we have seen the pre-hospital management. Emergency treatment of the stroke is which for revascularization we used IV thrombolysis and endovascular mechanical thrombectomy, and we will see the post-stroke immediate post-stroke management in these patients, management of complication and long-term management. So as you know, stroke remains the second leading cause of death worldwide, and treatment of stroke should be in an emergency basis, and every second is important in treating stroke. So when stroke occurs, we should identify the time when the patient was last seen normal, and this is very important to put the patient into window period within the time window for acute intervention. Basically, the patient should be assessed for the severity of stroke using the NIHS score, and we know the symptoms of stroke we can identify using this BFAST mnemonic, and whenever the stroke is identified, the patient should be rushed to a stroke ready hospital. We have seen this. With every second, 32,000 neurons are dying, and we are losing 8.7 hours of life. This is a slide of natural history of stroke. If the stroke remains untreated, in the initial MRI, we can see that the patient has a diffusion restriction lesion, and the FLAIR image is negative, and there is an MC occlusion. And if it is not treated, the occlusion may open after some time, but the patient will definitely take clear-cut definite stroke. So every second in stroke treatment is very important. So in pre-hospital management, there should be a stroke code pathway activation should be done. Emergency should be to identify the symptoms of stroke and differentiate between the stroke mimics and stroke chameleons. And in the pre-hospital itself, if you have the provision, then we should start the treatment for hypoglycemia, which is the most common mimicker of stroke, anti-seizure medication and anti-arrhythmic medication. As we said, if the patient has life-threatening arrhythmia, we have if the ambulance facility allows us to have this medication, we should administer before reaching the hospital. The identification of stroke and mimics may be difficult for the field workers. So these kind of field assessment scores can be applied. This is an example of Los Angeles pre-hospital stroke screen, which can be applied to identify stroke and exclude the other stroke mimics. This include if the patient is more than 45 years of age and patient have no past history of seizure, and the patient was ambulatory before the onset of seizure, and if the glucose is within normal limit, there is no hypoglycemia or severe hyperglycemia, then the chances that the patient is not having the stroke mimic, the chance for stroke is more, with the obvious symptoms of facial weakness, arm or leg weakness. This screening scale will help the field worker to identify the stroke. When the ambulance faculty can identify it is a stroke, and we can rush the patient to hospital. And there is importance of this pre-notification system. If the stroke-ready hospital is pre-notified that the patient is arriving with the symptoms of stroke, this can decrease the door to imaging time, which is very important, which can be done within 25 minutes, and it can also decrease the treatment onset to treatment time if the hospital is notified before arriving. This is very important. We have to have this pre-hospital management of stroke patients by notifying the patients and this identifying of the patient by this screening system. So what we do when these stroke patients arrive in a stroke ready hospital? The first and most important is the stroke code activation. Every hospital has different protocols. There are some stroke codes which are announced in our speakers. In our setup, it is a WhatsApp group message. I will come into that. Every emergency should be managed like ABC. Airway, breathing, circulation should be the first priority. If the saturation is less than 94 we should put on oxygen. The first important investigation should be done is the blood glucose level, and this ECG and troponin can wait, and the next investigation is the imaging. Imaging can be CT based protocol or MRI based protocol. We should prioritize all examination history, examination, and the imaging should be ideally done within 20 minutes in more than 50% of the patients who are in the window of thrombolysis. And the revascularization procedures with the IVT or endovascular thrombectomy should be done as quickly as possible. And within 1 hour, the patient, the aim of our treatment should be to revascularize the patient within 60 minutes, because every second is important. Time is brain. So this is the WhatsApp group we have when the patients arrives in our hospital. The urgently we have everyone is receiving this MRI technicians, every staff members. We are ready to receive the patients. This happens in our hospital. This happens, and when video period comes, then our residents came and put the group. This is happening very fast, and so that the patient can be taken for urgent treatment within 1 hour. We can give him thrombolysis or endovascular treatment. So with the CT scan, we can identify the patient is having no bleed. Then we can identify, we can give him emergency thrombolysis. So for thrombolysis, if there is no bleed and there is no fully evolved large subacute infarct, there is no coagulopathy, and there is no major surgery, the patient is eligible for IV thrombolysis. Early CT changes of hypoagenation is not a contraindication for thrombolysis. And CT angiography with the other modalities of large vessel occlusion identification is required for mechanical thrombectomy. And multimodality imaging like CT perfusion, MR perfusion is required when the patient arrives in a late window, if more than 6 hours. So we in our hospital uses the MR based protocol because it can easily identify the stroke mimics, and also it includes MR angiogram which can identify the large vessel obstruction. So in patients with potentially disabling stroke, IV thrombolysis is indicated. The time window is usually up to 4.5 hours, and the BP should be less than 185/110 prior to lysis. We can give antihypertensive maximum of 2 doses, and we have 2 thrombolytic agents. One is the altiplase, which is given at a dose of total 0.9 mg per kg, which is given as a 10% bolus followed by infusion of over 1 hour. The other agent which is equally effective is tenecteplase, which is given at a dose of 0.25 mg to 0.4 mg per kg, which can be given as a quick bolus. That is the advantage of tenecteplase. So when the patient present to us with a disabling stroke, if the time onset is less than 4.5 hours, we can do a CT scan, and if the patient has a deficit, and we can give thrombolysis, and if the CT angiogram or MR angiogram shows the LVO, then we can proceed with the mechanical thrombectomy without waiting for the result of improvement with the IV thrombolysis. If the patient present with a late window, that is more than 4.0 hours to 24 hours, then we can do advanced imaging to look for eligibility for IV thrombolysis. Still, if there is a mismatch between clinical and perfusion mismatch is there, then a patient can be given IV thrombolysis up to 9 hours. I will come to that, and then based on dawn and diffuse criteria, patient can be selected for mechanical thrombectomy. So this is a CT based imaging. We can see the red core and which is surrounded by the penumbra, which can be salvaged in this patient. This is a CT-based protocol. Same can be done using MRI perfusion-based imaging. The core is denoted by the diffusion, and the penumbra is denoted by by saving this penumbra, we can salvage the patient. Coming to late window, this is a new modification. IV thrombolysis can be given for this late window based on the results of these trials. So this epithet trial was showed that if the patient has perfusion diffusion mismatch up to 3 to 6 hours, the patient can have increased perfusion with thrombolysis therapy. And extent trial also proved that based on perfusion diffusion mismatch, the patient can be eligible for thrombolysis. There are also ECAS trial, which also prove that if IVTPA is given, if there is a mismatch, then patient got benefit. So in the this up to it is recommended that up to 9 hours, if we can demonstrate a mismatch based on these imaging modalities, we can even go for thrombolysis. So we see that the aim of our treatment is to save the penumbra. So initial 6 hours we can do the basic CT or MRI images. Multimodally imaging is required when the patient present with later onset of window. This is a rapid software which is available in many places, but this is very costly to distinguish between the perfusion and mismatch. So before thrombolysis, only the blood glucose level is the important test to be done before thrombolysis. The results of other tests should not be waited. We should not wait for the other result. We can thrombolysis the patient only after seeing the blood glucose. If the blood glucose is showing hypoglycemia or hypoglycemia, treat that first. And ECG, all this kind of investigation can wait before thrombolysis. So the IVTPA and tenteplase are the two agents. Tenteplase is the new agent, which is analog of IVTPA, which is made by changing the genetic code in the TPA. It is more lasting in the system, and the advantage of tenteplase is it can be given as a bolus injection. We need not wait for 1 hour infusion that is needed with the alteplase. The alteplase has also risk like angioedema, and it is less fibrin sensitive, and various trials have proved benefits of tenteplase up to 9 hours. These are the summary of the various trials in thrombolytic agents. The initial trials were in 1995. Initially it was not proven effective in 6 hours. Later trials found out NINS trial found its effectiveness in 3 hour window. Then various trials, Atlantis, ECAS, H100, those trials prove that this effectiveness of thrombolysis, we can actually do thrombolysis within 9 hours. The tenteplase also initial trial was in 2015. The various trials found similar efficacy. Initial trials found similar efficacy to alteplase. Now it is shown that in large vessel occlusion, tenteplase combined with mechanical thrombectomy is more effective than alteplase. There are many trials which are going to look whether thrombolysis is needed before mechanical thrombectomy. I will come to that. These are the basic difference between alteplase and tenteplase. The half-life is more with the tenteplase, and it is more fibrin specific. It is not inhibited by prothrombin activation inhibitor, and it has no procoagulant effect. So recently published data whether to give thrombolysis in patient before thrombectomy is needed. This was analyzed based on the results of these randomized control trials, the David T. Direct Mr. Clean trial, SKIP trial, the SIF trial, and Direct trial. The meta-analysis of these all these trials has proved that the overall benefit of bridging therapy, that is to give thrombolysis before mechanical thrombectomy, is advised. We have to give if the patient is eligible for thrombolysis. So this data do not favor mechanical thrombectomy alone. If the patient is in time window and there is no contraindication, we should give IV thrombolysis before mechanical thrombectomy. So in treatment centers without the capability of on-site mechanical thrombectomy should initiate IV thrombolysis and pursue the immediate transfer for mechanical thrombectomy without waiting for the completion of IV thrombolysis. So when thrombolysis is done, the blood pressure, the management include blood pressure control. The blood pressure should be maintained less than 180 to 105, and agents like labetalol, hydralazine can be used. Patient should be adequately hydrated. Blood sugars should be maintained between 140 to 180 milligram per deciliter, because hypoglycemia and hyperglycemia is detrimental to brain. If patient develops seizures, then anti-seizure medication should be given. If patient is having a large stroke and there is chance for and there is significant edema developing, then 3% saline should be started, and mannitol can be given in emergency cases. And constant monitoring should be done, and patient should not wait to see the result of IV thrombolysis. Patient should be urgently taken for mechanical thrombectomy, and after all this procedure, the patient should be readmitted in ICU. If any deterioration occurs, urgent CT should be taken to look out for bleed, and if there is significant edema and bleeding, then decompression should be done to reduce the ICT. And if there is no worsening and patient is all right, and CT scan should be repeated at 24 hours, and we should start him on antiplatelet or anticoagulant therapy. So how blood pressure is maintained? If the patient is comes to you with a BP more than 220 or 120, and he is not a eligible and it is not controlled and is not in the window of IV thrombolysis, there is no need to urgently reduce the BP, because it may be a compensatory mechanism. So it is not advised to bring down the BP urgently if the patient is not eligible for IVT. And then it is recommended that only 15% reduction during the first 24 hours is recommended. And before thrombolysis, if the patient is taking for thrombolysis, the BP should be reduced to 185 by 110. And after the procedure, it is less than 180 or 105 in the 24 hours after IV thrombolysis administration. If intra-arterial therapy is administered, then the optimal BP management is still known, but it is reasonable to keep the BP below 185 and 110. This is the last month publication in Lancet, which showed that if BP is intensively controlled to less than 120, there is a detrimental effect. So they recommended that the intensive blood lowering after recanalization is not advised. What about the glucose? The glucose level should be maintained between 140 to 180 to closely monitor and prevent hypoglycemia and also hyperglycemia. And hypoglycemia, if occur, it should be treated urgently. And temperature also should be maintained. If more than 38, identify any source of infection, and it should be treated. It is found that the temperature below 37 and above 39 is associated with increased risk of hospital death. Therapeutic hypothermia is a promising neuroprotectant, but it is still not proven in acute ischemic stroke. So other management include the swallow assessment. The very important part is the nutrition. Patient should be checked for his deglutition ability. Using 30 ml water test. Other video assisted test or endoscopic test can be done if there is significant deglutition defect. Then if the patient is not able to swallow, then a Ryle's tube should be put to prevent aspiration pneumonia. In case of seizures, anti-epileptic drugs should be administered. Nursing care should be there, and prevention of bed sores should be a priority. And if the patients are paraplegic and lower limbs are not moving, then DVT prophylaxis should be administered using a single dose of heparin. In patients who are we cannot give heparin, pneumatic compression stockings are advised. And patient should be admitted in a stroke unit, and we should identify the etiology of and mechanisms of stroke. And patient have ECG, echocardiogram, and 24-hour telemetry, Holter monitoring in required cases. Blood workup including lipid profile, homocysteine, and in young patients, ANA, APLA, ANCA, sickling test, and Triple H serology, and in patient with a suspected patent foramen ovale transesophageal echocardiography should be done. And this is a busy slide, but it is very important to whom thrombolysis should not be given. So if a patient has a history of ischemic stroke or severe head trauma in the past 3 months, it is a relative contraindication for IV thrombolysis. Patient has previous intracranial hemorrhage, and patient is having intraaxial intracranial neoplasm, and patient has GI malignancy and GI hemorrhage in the previous 3 weeks, and intracranial or intraspinal within past 3 months. These are a contraindication for IV thrombolysis. And any symptoms suggestive of subarachnoid hemorrhage and persistent rise of BP. If we are not able to bring down the BP by 2 antihypertensive drugs to less than 185 and 110, then the patient should not be given thrombolysis. If there is an active internal bleeding, there is symptoms presentation suggestive of infective endocarditis, and if the patient is having suspected aortic arch dissection, active bleeding diastasis, the thrombolysis is contraindicated. And when we send the complete blood count and the platelet count come as less than 1 lakh, we should stop the thrombolysis. And if the patient is on anticoagulant use, if the INR is more than 1.7, prothrombin time more than 15, APTT more than 40 seconds, this is a contraindication. And for low molecular weight heparin, if the patient has received therapeutic doses, that is BD doses of heparin is given, it is a contraindication. If the patient is given OD doses for the prophylactic dose, then thrombolysis can be done. If the patient is taking a direct factor Xa inhibitor or direct thrombin inhibitor in the last 48 hours, then based on the lab tests like APTT, INR, occurring clotting time, thrombin time, and factor Xa levels, if these are available, then and they are normal, then we can thrombolyze the patient. And if the CT shows hemorrhage, it is an absolute contraindication, and there is very obvious hypotensity, extensive lesions, then patient should not be thrombolyzed. Then there are some conditions which can be considered case-to-case basis, in which there is only minor or rapidly improving cases. If the then patient can be if still deficit, it is a disabling deficit, we should give. If the blood sugar is less than 50, we should first correct, and if it is, we should find it is the cause of stroke, the deficit. If there is a serious trauma, not head trauma, the other trauma in the previous 14 days, major surgery in the 14 days, history of GI bleed, not in remote GI bleed or genitourinary bleed. These should be if the patient having seizure at the onset. These are not contraindication. We can consider if the stroke is disabling, we should give. In pregnancy, we can give IV thrombolysis after explaining the risk. If the patient is having a large untreated aneurysm and arterial puncture at a non-compressible site, the role of IV thrombolysis is not documented, and if it is untreated intracranial vascular malformation, then also the efficacy of IV thrombolysis is not proven. So we should be very careful if in giving IVT, especially in the late window to patients more than 80 years, anticoagulant use, and in severe strokes. So we can give in this patient after discussion with the patient and patient relatives. And if patient is taking DOACs and it is more than 48 hours before IVT, then it is no problem. But the patient is taking DOAC within 48 hours, then there are some guidelines. If the patient is taking dabigatran, then it can be reversed using idarucizumab, and thrombolysis can be given. And in case of other DOACs, then the other tests like the drug levels and it should be done before. And the Japan guidelines allowed if the patient if taking DOAC in 4 hours, then the alteplase dose should be reduced to 0.6 mg per kg instead of 0.9 mg per kg. So if the patient has large MCA infarct and there is edema, then the 3% saline should be started and Mansure should be given in emergency. And large bone flap removal with duroplasty should be done in a large MCA, significant MCA stroke with significant edema and chance of herniation. And it is found to be effective to reduce mortality in patients less than 60 years, and it also improve the outcome. In patient more than 16 years also it is found to reduce the mortality. The surgical management of the large MCA stroke should be to be discussed in later study. In case of cerebellar infarct, there is a chance of upward cerebellar herniation and tonsillar herniation. And if it is large, then posterior fossa decompression is recommended. So to find out the cause and the secondary prevention of these patients, the patient should be having investigated with the imaging, cardiac evaluation, HbA1c, lipid profile, other treat, and revascularization should be, carotid revascularization should be considered in patient with a significant carotid stenosis. And if the patient having atrial fibrillation as a cause of stroke, then we have to start anticoagulation, oral anticoagulation based on the size of the infarct. We can, if the size is small, we can start within 4 days, and if the size is large, we should wait for the 14 days after the stroke to avoid hemorrhagic transformation. It is recommended that the patient should be given dual antiplatelets. In both the chance trial have proved that the short-term dual antiplatelets for 3 weeks, the combination of aspirin and clopidogrel should be given in minor stroke and TIA, and it should be followed by lifetime single antiplatelet therapy. If the patient having found out to be LV thrombus, 3 months anticoagulation should be given. So the three evidence-based therapy which is found efficacy in stroke is thrombolysis within 4.5 hours, thrombectomy within 6 hours, and up to 24 hours in selected cases. The treatment of patient in stroke care unit and decompressive craniotomy. These are proven evidence-based treatment for acute ischemic stroke. Coming to the treatment of atrial fibrillation and cardioembolic strokes and non-valvular atrial fibrillation, all these agents, dabigatran, rivaroxaban, apixaban, and endoxaban, can have been proved to be non-inferior to warfarin. So, in non-valvular patients, we prefer DOACs or vitamin K antagonist. And embolic stroke of undetermined source. This is a ESS term. In this, the anticoagulants should not be given. We should not, if we are not able to identify the source of embolus, we should not give anticoagulants. The evidence is not favoring the anticoagulants. This is a summary of what we should give in patients with the secondary prophylaxis. In patients with atrial fibrillation, anticoagulation should be given. Heart failure, especially ejection fraction less than 45, and 45 anticoagulation should be given. LV thrombosis there, anticoagulation should be given for 3 to 6 months. Left ventricular assist device, then anticoagulation should be given. In PFO related stroke, antiplages or anticoagulants both can be given, but if it is a young stroke and PFO is proved as the etiology of stroke, then surgical correction of PFO should be done. In mitral stenosis related stroke, anticoagulations, and mechanical aortic and mitral combination of anticoagulant and antiplatelets should be given. In bioprosthetic valve, we can give on antiplatelets, and infective endocarditis, the treatment should be antibiotics. In aortic arch atheroma, antiplatelets and statin can be given. So after the stroke occurs, the rehabilitation is very important. But early aggressive mobilization with the physical therapy is not advised. Our trial has showed a negative result. Early mobilization is needed, but it should not be severe aggressive. Then family member-led physiotherapy and virtual rehabilitation and telemedicine should be as a part of rehabilitation. So, medical management of stroke is very intensive, multidisciplinary and comprehensive. All aspects are to be given to treat the patient in a facility with a stroke unit, and the revascularization with the IV thrombolysis can be done. We have seen up to 9 hours, and endovascular therapy 24 hours and beyond. So we should remember the time is brain. Every second is important. So rush to patient with a stroke ready hospital, IV thrombolysis, mechanical thrombectomy, and post-stroke care in a stroke unit, rehabilitation. This is the line of management in a stroke. I will finish with a video.
In an ischemic stroke, a piece of plaque or blood
This is what happened in small strokes. The embolic, the atheroma
forms an embolus, which can travel through
embolus goes upwards and traps to distal vessels.
in one of these vessels. Once stuck, the clot can prevent blood from flowing to areas beyond the clot. Cells in the surrounding tissue begin to
The
starve.
acute, the surrounding area develop infarct, and it is surrounded by
At-risk tissue
area at risk is called penumbra. The aim of our endovascularization, IV thrombolysis, is to revascularize the penumbra. Even though in our country doesn't have the CT scan ready ambulances, this is available in other Western countries. This is a CT available ambulance.
of a protein called tissue plasminogen
The
activated.
patient can be with a stroke can be undergone CT scan within the ambulance itself, and IV thrombolysis can be administered
The embolus is
in the ambulance, and
which acts as a net holding
this is the how IV TPA works by binding to plasmin.
on the surface of the embolus. Plasminogen is then transformed into an enzyme called plasmin,
and lysis of clot occurs.
The glue holding the embolus together dissolves.
And the patient can be transferred to a mechanical thrombectomy ready hospital if tested.
Can receive oxygen and nutrients, returning to healthy function. With stroke, the key factor is time. The emergency stroke treatment unit has the potential to save brain tissue by diagnosing and treating patients with TBA.
So we should act fast.
The hospital.
Thank you. These are my references.
So it's been a nice and extensive coverage of pharmacological treatment in stroke. So now again, as I said, turf is set for the master to come and talk about interventional management of stroke. Dr. Gaurav Goel, he is director and head of interventional neurology at Medanta. He has, to his credit, more than 50 national and international publications. His area of specialization is neurointervention and acute stroke. He has been pioneer in doing most of the devices which comes for acute revascularization therapy in the country. I mean, so if I consider that I am a regional face for acute stroke treatment, so he is Indian face for acute revascularization therapy abroad also. So he does a lot of work with devices, tools, and his interest remains how to implement intervention for betterment of stroke treatment. Meanwhile, if any questions or queries, if somebody has in mind, please till the time. Are you ready? Oh, perfect. So over to Dr. Gaurav.
We can still take questions, it's fine.
Yeah. So, there any questions, or maybe we can take after this talk.
One thing I want to say that those CT stroke ready ambulances are available.
Yeah,
in our
are
country.
available. Yeah. So, I mean, it was a nice coverage. CT ambulances are there in our country also at a couple of places. Not very routinely available though. You have in
No. So
it's
there
in
are two.
Coimbatore, I remember.
One in
One is with
Coimbatore and one in Calicut.
Calicut. Yeah. So that's a very nice thing. And maybe we also have an ambulance, stroke ambulance, but unfortunately CT is still waiting to be put inside that. So and yes, sir. Yeah. So that's another thing was the long slide of contraindication. So I would just mention, over last decade or so in acute stroke therapies, there has been 3 major advancements. One is of course stroke unit, IV thrombolysis, and third one, which Dr. Gaurav would be covering, about taking the clot out through thrombectomy or aspiration. So these 3 things have been major cornerstone in acute stroke treatment in last decade or so. So for IV thrombolysis, if that long list of contraindication, that should not scare you. I mean, the whole thing is because the whole slide was a big with so many contraindications. I'm not that aggressive person, but somebody who will say the only contraindication in IV TPA or acute stroke treatment is if you have a hemorrhage in the brain. So only thing you need is a CT scan and a blood sugar. And these 2 things are done, you thrombolize, unless until your patient runs away, climb on a tree. Over to you.
So that's the dictum we too follow, like thrombolize until unless there is a major contraindication. If it doesn't work, we come into picture and we can do mechanical thrombectomy. So why are we talking about mechanical thrombectomy in acute stroke? Because this is now evidence. If you do not offer this to the patients of stroke, you are actually committing a criminal negligence. So all the patients who are eligible should receive a mechanical thrombectomy. And it's surprising, like even if I ask you today, as a community we fail. So what's the window for acute stroke treatment today? Anyone? Up to 24 hours, but you see, you are the only one who's telling. So we are shaky because we go into the nitty-gritties, 6 hours, 4.5 hours. It becomes very confusing. I think we have to start speaking in one common language. It's up to 24 hours. send the patient to stroke ready hospitals. They can then go over their eligibility, ineligibility, which patient will fit in. But at least we should increase the denominator. If we do not increase the denominator, we will never succeed. And this is what all the trials have tried to show us, that the number needed to treat, like number of patients you should treat to make benefit. So for a heart, and cardiologists have done such a great job that they have convinced us that any patient of heart attack, anybody and everybody, you don't even need to be a doctor. A liftman can tell you that take him to a cardiologist, he will put a stent. And that number needed to treat is 19. While in stroke for mechanical thrombectomy, that number is actually less than 3, it's 2.4. So the impact of doing a mechanical thrombectomy in stroke is far higher than what you can do. It's actually much more than using a defib in a ventricular fibrillation. So if you keep those things in mind, it's so important, and it's a very, very powerful tool to treat these stroke patients. And I think that's the only disease for which we have now so many randomized controlled trials. When we started doing this 14, 15 years back, we used to get a lot of flack because the evidence was not there. In fact, we went through a lot of negative trials. But in last 5, 7 years, now we have 9 randomized controlled trials, and I don't think there is any scope for doing more. So as I said, the time is less than 24 hours. We can divide it further, 6 to 16, 16 to 24, based on the trials, level of evidence. But clearly, if the patient comes to you within 24 hours, you should screen them. If they're eligible, do mechanical thrombectomy. And do not mistaken that if we say mechanical thrombectomy, we are not promoting IV TPA. IV TPA should be given to all the patients who are eligible for IV TPA. But do not wait for the IV TPA to get over before you start for mechanical thrombectomy. So if you know the patient is having a large vessel occlusion, thrombolize the patient. If you have in-house mechanical thrombectomy, start shifting the patient to lab. In Indian settings, everything takes time. You talk to the patient, clearance, lab gets ready, somebody comes from their home. If patient improves, you can stop at any point. If patient doesn't improve, you are not wasting time. If you do not have that facility, you refer it to the other center. So you give TPA and start shifting. If you withhold, then it's not fair. Now, who should get it? So typically within first 6 hours, it's very clear. If a patient was good prior, we should treat it. But now more and more evidence is coming that even if the MRS, pre-MRS was not so good, you can actually make him go back to the same level at what he was. So that's not an absolute. We initially started talking only of large vessel occlusions of ICA, MC and basilar. But now more and more we are moving towards medium vessel occlusions, distal vessel occlusions, which can also be treated by mechanical thrombectomy. So NIHS of more than 6 was the criteria. But somebody who is having a visual symptom, if I am going to turn a hemianopia or a blind, I will lose my professional thing. I can't work anymore. So maybe depending on certain circumstances, even in low NHS score, you may be asked to do a mechanical thrombectomy. And we initially thought like if the aspects is more than 6, that means the infarct has not yet evolved, then only we can do it. But now I'm going to show you more evidence which is coming up, which shows that even if it's a moderate size infarct, it's better to do than not to do. When it goes to beyond 6 to 24 hours, till now we were dependent on CT perfusion and MRI, and still better to do it probably if you have the facility. And there are guidelines established which, as the previous speakers have very nicely illustrated, that we try to see how much of penumbra is left, how much is the core, and depending on the mismatch, then we can make a call. But these are the latest studies which are coming up, which are now comparing just the plain CT scan versus CT perfusion and diffusion weighted imaging, and there is no difference. So if you take this decision just based on CT, and as you rightly said, penetration of CT is far more in our country, in fact better than most of the Western countries, then you can make this decision just based on CT scan. And more and more meta-analysis is coming, in which if you do not have these facilities readily available, if you think you're going to waste more time doing these examinations, then probably it's not worth it. Just go ahead. The only caveat is you need to have a good radiologist to interpret those CT scans. Sometimes, you cannot have both the factors, that you are just relying on a plain CT scan and you don't know how to read a CT scan well. So then it will be a disaster. So there I think the perfusion imaging or MRI is helpful, because even if you are not well trained, you are able to see those pictures, and as we will see in our talk, it's very simple to see at any point of time. So this is an ideal patient, a best case scenario, which I say. Youngish patient, very favorable anatomy, high aspects, which mean the infarct size is small, and there is a large vessel occlusion. So this is the typical ideal candidate we see. So MC is occluded. We do a perfusion scan very routinely in our center, because like just one look at it and you know that there is no big infarct on CBV and there is a large penumbra. So this patient will definitely benefit. So you take these patients to DSA, and this is the timeline. If you can see, we have mentioned a timeline. So everybody knows they are on a clock. Time is brain is a very cliche, but it still works. So you go inside, take the clot out, opens the artery, and the patient works. Now, when not to intervene is if you do not have a good penumbra, if the patient is already having a large infarct. So again, the CT may not show you, like if I change the window settings, you will be able to see that large infarct. But sometimes if you are not able to read it, like you are seeing on a WhatsApp where you cannot change the window setting, your perfusion or MRI will help. Like in this case, you can clearly see on CBV, there's already a big infarct which is setting in. Similarly, you can see it on the CT angiography source images. Now, whatever you do for these patients, it will be futile. They are two-way, like they do not have a good collateral, they will not benefit for this mechanical thrombectomy. So similarly, these patients, poor collaterals, large infarct which is already settling in, I think with the resources which we have, we will not do a lot of justice to these patients. So I'm putting these slides here because we need to be, sort of knowing the fact, because sometimes when we open up these arteries, these patients remain MRS 4, 5, burden on society and family. They struggle for 6 months, get numerous infections, and eventually it's a long struggle for the family. Having said so, the new data which is coming in, so barring very low aspects of 1 and 2, we are seeing that even if you do for aspects 3 to 5, the outcome of these patients with a proper care is much better than just leaving them alone on medical management. And this is a very latest trial which has come up, the Rescue Japan Limit study. So they took patients within aspects of 3 to 5 with a large vessel occlusion, and they took the patients till 24 hours. Of course, they excluded very low aspects of less than 2, which practically means there is no brain left. And what they found was significantly good outcome in endovascular arm versus medical management. Yes, there were more hemorrhages as expected, but it didn't turn out to be that detrimental. So across all subgroup analysis they conducted, they found that even in these moderately large size infarctions, the mechanical thrombectomy do have a role to play. Now, when we go to interventional meetings, we have our own differences on how do we want to do mechanical thrombectomy. So there are numerous ways of opening these arteries. The ultimate goal is we want to reach to a TICI 2B or TICI 3. So these are sort of terminologies which has come from cardiology literature but now adapted to brain literature, that most of the arteries should be filling. So it should not just be the opening of the proximal arteries. If you are not perfusing the distal vessels, it's of no use. So we target at least TICI 2B, 2C or 3 in our practice. So we can decide on multiple practice. So, sorry. So typically the stent retrievers change the game of stroke mechanical thrombectomy. And the animations, everything looks simple, and these are very old animations, and because there are students here, I think we can just let it run. That you cross the clot with a microcatheter and wire. It's similar to the cardiology practice. We go through femoral groin, You put a guiding catheter in the neck. Through the guiding catheter, a small microcatheter is passed as shown on this animation. And these stents, they are self-expanding. So the cardiac stents are balloon expanding. That means you need a balloon to expand those stents. But these are self-expanding. So once you take the microcatheter off, these stents will self-expand and will engage the clot. You let the stent sit there for a couple of minutes so that it sinks in the clot, and then you pull out the stent. So practically you are engaging the clot and pulling it out. And you do it once, you do it twice or thrice, and most of the times you will find that the clot has come out, until and unless it's a very hard clot, and for which we'll see different strategies. So this is the way the mechanical thrombectomy works. And as the time has grown by, we have seen numerous types of stent retrievers, large stent retrievers which have come in, and our debate is which stents to use. So whether to use 4 millimeter, 6 millimeter, 20, 30, 40, and we have numerous different studies to show, okay, this works better in this. Some studies promote 6 millimeter, some studies promote 4 millimeter. What we need to understand is we just need to slightly oversize from the size of the artery. So this, what we believe, if there is an ICA, we like to use a 6 millimeter stent retriever because a 4 millimeter will fall short. If it's an MCA, which is a smaller vessel, you don't need to do it with a 6 millimeter, 4 millimeter will just work well. So that's the rule of thumb which we follow. And this is one of the representative case. Again, you can see a CT scan, a big penumbra on CT perfusion, and the right MCA which is occluded. Typically, this is the vessel which is occluded, brain is not getting the supply. We cross with the microcatheter, the stent retriever is in place, pulled it out, and this is the TICI-3 sort of a recanalization where all the arteries have opened up. And this is the follow-up CT scan, small patchy infarcts, but nothing major. So that's the power of mechanical thrombectomy. The other technique which is very popular again is the aspiration. This is actually the simplest to do, where, and I think Arvind is going to talk about the recent advances, so maybe I'll just skip this aspiration part. It's basically taking a big bore tube to the clot and aspirating it. Maybe we can just show that, yeah. So this is like a tube which is there. You don't even need to cross the clot. You put it proximal to the clot, connect it to a suction pump, and just turn on the suction, and the clots can get aspirated. Again, like a caveat is everything looks easy when it's in animation, but this also takes sometimes numerous passes to do. And again, we have advances in catheters. They have become bigger, they have become better. We can navigate all those things very distally into the MCA and distal branches. This is how it looks. The artery is occluded. This is the aspiration catheter sitting right in the front of the clot. You aspirate it and it comes out. What we just need to make sure is we do not cause distal embolism. Sometimes if we do not remove it en masse, it can get fragmented and cause distal embolism. And this is the technique which we like to use in our practice. It's combining both stent and aspiration. So I want to have the best of the world. If I just use stent, I will only be able to take out soft clots. I may miss out on the hard clots. If I use aspiration, I may cause distal embolism if it's a soft clot. I don't want to waste time analyzing the clot. Maybe it's a mixed clot, whether it's a red or a white. So the best is to combine both the techniques. So you engage the clot using a stent retriever, then you go with an aspiration catheter and you pinch it. So this is the same step as we saw for the stent retriever. You cross the clot using a wire and a catheter, then you deploy the stent. This is how we are pulling back on the microcatheter. The stent is deployed. You take out the microcatheter and then you advance your aspiration catheter over it. So when we have placed the stent, now the clot is engaged in the retriever. So this is how the stent has engaged. Now we just need to ensure that we are holding it. So you will see a large bore tube which will go to, we wait for 4-5 minutes so that it sinks in. We can also use, this animation is showing balloon guide. We don't use that balloon guide. Okay, So we have turned on the aspiration. Now you can see. So this is the aspiration catheter which will go and it will sort of pinch the clot between the stent retriever and the aspiration catheter, and now you remove it en masse. So when you do this, your chances of recanalizing in one go is higher, probably. But is it better for the patient? We will see from the data. So we have numerous modifications. I'm just going to skip past it. We have sort of reframed it to a dual aspiration where we do things little bit differently. That we put a stent, as we see in the animation. We do exactly the same things. The only difference which we do is we use two aspiration pumps. So one at the neck level and one at the brain level. So the chances of pulling that clot goes even better. That's what we feel in our experience. And this is how it looks: stent retriever, the aspiration catheter, and then you pull the whole thing out, and the clot will come pinched like this at the interface of the aspiration catheter and stent retriever. Everybody gets happy. And that's what we typically do for almost all our patients. So that's our strategy now. Over a period of time, we have switched completely to Solumbra for all sort of clots, howsoever distal they are. We want to go and pinch them with a stent and an aspiration catheter and take it out. So we have tons of these pictures in which the clot is pinched at the junction of the aspiration and stent retriever. So this is the index case which I like to show, because this is what changed our practice in 5-6 years back. A posterior circulation, PCA was blocked. We tried opening it up using a stent, aspiration didn't work, but when we tried it with Solumbra, it just worked it in one go. And we realized this is the future, and since then, for all the patients, we do this as a first therapy. So we keep debating stent, aspiration, both, what technique to use. I think whatever works best in your center, whatever works best in your hand, and everybody has a different way to do it. All the trials so far have failed to show superiority of one over the other, of stent versus aspiration. We thought Solumbra will be better, but this is the large trial Aster 2 which was done, and they found that there was no difference in patient's outcome whether you used only stent versus aspiration versus Solumbra. So what we have learned is that probably when we do this, you have a better first pass effect. You are able to take the clot out in first pass. But eventual functional outcome is not different, because you can do a second and third pass probably in next 5-7 minutes, and it doesn't really change it. We still feel we may get better data. We are still where we were in 2011 and 12, where everybody was telling it mechanical thrombectomy doesn't work, and in few years time we could modify it. I think Solumbra will make a comeback because a lot of people do it differently. But as of today, we do not have a clear-cut evidence, barring that it works better in taking out these clots faster. So again, typical patient with a tandem occlusion, 7.5 hours. Okay, it got stuck. It's not moving. Yeah. So this is how it looks in clinical setting. So this is the patient. We try to rapidly make a video in the emergency. Our fellows are trained to do that. That quickly make a pre-video of the patient, send it in the group so everybody knows what they are looking at. So patient is slightly unresponsive, not following command. Of course, the left ICA is completely occluded. Patient is right-sided hemiplegic. So quick assessment. We go in. The artery is occluded. We open up, get the clot out. It's flowing now, good TK3 recanalization, and this is the patient few hours later, I guess. We do not have the audio here, but he is able to comprehend now, obey, able to move his arms and legs. So not very often we do get immediate good outcome, but there are certain patients who do improve clinically if they do not have a baseline big infarct. So I think this part was already covered by the previous speaker, because now we start to get cocky. Okay, we can get out everything, we can open everything. Why do we need to give IVTP and waste 40-50,000 and probably 20-30 minutes? So there are pros and cons. Like, if we do it, we are combining the effect. We are synergizing the effect of both. But of course, we are increasing the bleeding risk, increasing the cost, increasing the time. So the best way to do is to do trials. So there were numerous trials because this question became important. And as the previous speaker showed, we we have done 5 and 6 of them. Only 2 of them came positive. So this is the meta-analysis. We still do not have an evidence to skip IVTPA. I think it makes sense. And in our own practice, we feel that because whatever you do, small distal embolism sometimes is there that is taken care by TPA. Whatever we do in Indian settings, it's very difficult to go into the lab in next 5 minutes. So while we are waiting, setting things up, the IVTPA is working. So let's not skip the IVTPA till we get more evidence. In fact, we are now getting evidence that while you are doing mechanical thrombectomy, even if you have opened up the artery, give a bit of thrombolytic agent, and that improves the patient's outcome. So posterior circulation is no brainer. If you do not open the closed basilar artery, the patient is going to die. So the outcomes of endovascular treatment are better. So basics and best, Bausch, attention. So we have again like numerous trials because we do need them for medical legal reasons, and all of them have clearly shown that it's better to open up the artery rather than not to open up the artery. So for anesthesia, again, there is a debate whether we should do them in general anesthesia or IV sedation. If you do under general anesthesia, make sure the blood pressure does not drop off because otherwise the collaterals will go. We typically like to do them under conscious sedation until unless it's a left-sided patient is absolutely restless, then there is more chance of us injuring the arteries while we are passing these microcatheters. But if we can manage these patients under sedation, we will try to do that. Not all clots work come out easily. Some are adamant despite whatever we do. So this is one of the patients. We thought it's a typical patient, so we went ahead, did our technique, opened up the artery, but it closed down again in few seconds. Patient was very hypercoagulable, and we did numerous attempts, and we could just open up the artery a little bit, but it was getting closed time and again. So we tried all the possible combinations, stent retrievers, but some clots are just adamant. And when this happens, sometimes we have to combine the pharmacological treatment along with thrombectomy. So for this patient, we opened up the artery and then put these patients on GP2B3 inhibitors so that they do not reform the clot and keep them on these infusions. So this is also becoming very popular with mechanical thrombectomy to give tirofiban or Riopro infusions for few hours so that these arteries do not reocclude immediately, which is not looking nice to our patients. So ICAD, underlying ICAD, which is causing acute stroke, is very common in Indian population too, and almost 1 in 10 patients, we do see a situation where we have to deploy a stent in acute setting. So whether it's posterior or anterior circulation, so typically we will open up the artery and we'll find that there's a very severe ICAD, and if you leave it just like that, they're going to reocclude. So the best way is to put these stents and then start tirofiban infusion or a Riopro infusion so that they do not close till your antiplatelets take effect. So this is one of the example of anterior circulation where the arteries was blocked. We opened it up, but the moment we opened it up, we could see that there is a severe ICAD in the M1, M2 junction, and it was closing off. So we had to place a stent, and we did it, and we do a CT scan next day before loading these patients that there is no bleed, and then you give antiplatelets. Same thing, if there is a extracranial carotid occlusion, you again try with an angioplasty. If that doesn't work, then you place a stent concurrently. I think we have enough evidence now in the literature to show that it's safe to do these acute stentings in conjunction with the acute stroke. As I said in the beginning, now we are going far from the large vessel occlusions to medium vessel occlusions also, especially on the left side when it's occluding the M2s and M3s. We have these mini stent retrievers which can be navigated through a smaller microcatheters, and when you use them, it's the same technique which we are using for large vessel occlusion, just with a smaller microcatheter and more flexible devices. We can go and open up these distal vessels also. So distal ACA, distal MCA, they all can be targeted using these micro stent retrievers. Last few slides, when we are not able to go up, the access issues can be there because these patients by and large are vasculopaths, they are smokers, so all these arteries will be diseased. So sometimes if one artery is blocked, you can use the other side. If that also is blocked, you can use radial access, which is becoming very, very popular in neurointervention. If that also doesn't work, in few cases we have done a direct stick puncture. So we are very passionate about opening up the arteries. So even if we are not finding ways, we can do a direct stick puncture. The neurointervention started with direct carotid puncture, so we are going back whenever it's required. So we have done around 3 patients now with a direct puncture. That's our protocol, which is similar to any other. Like, it's just we need to define that in how much time we should do everything, and over a period of time we don't even need to look at it, everybody gets tuned to it. And so we have defined each areas, and together with neurology and radiology, we can manage all this. So we also like to use WhatsApp, social media. I think this is the best way in our country to notify everyone what we're gonna do. And this is a very old video, but we have time, right? So I'll just play this. So this was a stroke protocol pathway made for Medanta. Actually, it was made by our neuroanesthesia team for their own meeting. It has been around for 5-6 years. I don't know if I have shown this. We do it. Okay, we can get the audio from here. It's self-explanatory, so I'll just let it run for 5 minutes. So the code goes to everyone, like downright to the security person, so he can open up the lab, keep the lifts ready and everything.
There is a code brain rescue in emergency bed number 6. I repeat, there is a code brain rescue in emergency bed number 6. Please respond immediately.
So that's the list of a person to whom the stroke call will go simultaneously. Most of the times till now we have not seen the patient, not the neurology team, so they just announce and shift the patient for CT scan from emergency. And CT console is where everybody meets actually and say, okay, what's happening? Vedanta has this disadvantage because our lab is on 3rd floor. So it's like at least 5 to 7 minutes transfer time from emergency to up.
We have started the case. The readings are 4963. Patient is hemodynamically stable.
So this is basically how we do it, and then the patient gets shifted to. So I'll skip this last part, and we like to collect all these videos. So we encourage patients to go back, send what they're doing. So we have a lot of these videos, and they are satisfying at the end of the day. So this is typically what we do, and I think if we have to have a take-home message that less than 24 hours, large vessel occlusion, patient is having INHS, find more reasons to do than not to do. And even with low aspects, low NHS, medium vessel occlusion, it's evolving. The evidence is coming up. Give your patients a trial. And regarding the technique, whether we should use stent, aspiration, Solumbra, be comfortable in what you do. There is nothing wrong in either of it. So if you feel comfortable with stent, use that. So it's totally up to the center in what they are doing. So thank you so much for your attention.
Thank you, Dr. Gaurav. It was wonderful presentation, very nicely covered, and as very rightly said, I mean, medicine, though RCTs and meta-analysis give you clue to treat, but medicine is ultimately individual-based medicine. You do things what works best with you or with your institute is the strategy to be followed. Well, we have time for question and comments. It's as I said, it's a course. It's a relaxed course. It's not important to cover all talks also. We'll be in time. So if you have any questions or comments. So because after this, I'll be skipping the talk for surgery. Because surgery already discussed by Dr. Piyush. We have time. 48 hours is time for decompression. So window period is over. We have recanalized the vessels. So time to go back to sparks in brain. Dr. Atmaram, where is he? Oh, because I did not inform him. So, so maybe Arvind, would you like to take the talk? So anyway, so Dr. Arvind will continue from here about advancement in thrombectomy and aspiration. Dr. Arvind Nanda, a very dear friend of mine, he's a radiologist who is in Delhi. He is a faculty to medical college recently in Faridabad, and he goes all over the world. He is the one person who is comfortable in every lab, including mine also. He goes to Australia, he goes to Sri Lanka, Maldives, whatnot. All the places he can work day in, day out. Hello. So he has been traveling and he takes class residents also. And he travels a lot and he does cases everywhere. So he has experience and feel of patients and how do they work. So basically, before I hand over, before he sets up things, if you have any questions or comments till that time, Dr. Gaurav, what is the extent of infarct you would intervene? Let's say you have 2/3 of MCA. Hello. So you have 2/3 of MCA territory gone, with some penumbra still left in the vessel.
So if the penumbra is less than 20%, we do not. So it has to be like more than 20, preferably more than 30 for us to intervene.
So basically, where would you restrict yourself? Because nowadays it's said it is better to have a decompressed brain with complete MCA gone, still recognized vessel. Do you agree to that?
So as I said, like if you look at the data, that is showing you that yes, it works. Because
Yeah.
for even for large evolved infarcts, if you open up the arteries, the outcomes are better. But the outcomes are better as compared, like from an MRS5, the patient may become MRS3, but he is still dependent. If he
Yeah.
is bed bound, see the rehabilitation facilities in our countries are limited. Financial capabilities of the families are also limited. So we have to take a judgment call on that, that whether these patients will actually have a meaningful life afterwards or not.
Afterwards. So, putting so much money and then.
If like a 45-year, 50-year-old comes with largish infarct, still some penumbra, versus 75-year-old with the same situation, probably our decision and outcome will change depending on from rural or urban background, the kind of facilities they can have. I think it will change. So we have to take in account all those considerations.
And similar to that, how much brain stem, I mean, posterior circulation, as you were telling about, so opening a basilar or PCA, I mean, would you take into account how much brain stem is already knocked off?
Same thing, absolutely same
Same
thing.
thing.
Yes. So
Okay.
if the brainstem is gone, whatever you do is not going to work.
True. Are you ready, sir?
Do you have a
what-
different experience? Like,
Pardon?
do you do differently?
So far, I've been following this, but I've been seeing cases in conferences where they say that it is better to have an open artery, even if the brain is completely infarcted or maybe 2/3 or whole of the MCA is gone. Still, the outcome is better if you have an opened up artery rather than having a closed artery, because then probably rehabs also, I mean, works better with these set of patients. Obviously, changing from 5 to 3 may be important to someone, may not be important to someone. So that's a call. I mean, recently this is being discussed.
So it is for the right side of the.
Yes, sir. Very rightly, sir. Very rightly, yes. Because it is, if there are no financial, but there is a risk of hemorrhagic transformation. That's the biggest problem. You have a dead patient or a live patient.
No. So the Rescue Japan study actually answers that despite more hemorrhages, but they are not symptomatic.
Symptomatic, yes, yes.
So we have the evidence to go ahead and treat those patients. But honestly, like in our setups and settings, there are numerous restraints. So that's where I feel that we do not go full ahead in those patients yet.
But Gaurav, do you have a non-dominant and dominant hemisphere?
No, I think that doesn't
rational
matter.
into that?
No, I think that doesn't matter.
Because that also matter if it's a non-dominant right side, you can.
Nowadays it is, I mean, the
It's same.
trials and everything, it's same. Actually, it doesn't really matter.
Yes.
So over to Dr. Arvind.
Good afternoon, everyone. My job has been made very easy by the talks from Justin and my dear friend Gaurav. I won't be taking too much time into the details because we have been listening to this from last 1 hour, 1.5 hour, what stroke does. But this trial, as Gaurav mentioned, diffuse 3 trial really changed our perspective towards stroke. It started, earlier we were not doing stroke above 6 hours, mechanical thrombectomies. And window period for IV TPA was 3 hours. Later it changed to 4.5 hours. And the window for acute stroke mechanical thrombectomy changed from 16 to 24 hours with the diffuse and DAWN trials. But with the evidence based of CT perfusion or MR perfusion. 6 to 24 hours, if perfusion tells you that you have a penumbra which is more than 15 ml, then you must go ahead and do the case. If the penumbra is less than 15 and the mismatch ratio is less than 1.8, from the infarcted tissue to the ischemic tissue, then you should not attempt those cases. So I'll be dealing with them later on. This, where we stood earlier from 1995 to 2015. Earlier only this device was available, a coil-shaped Mercy device, and the recanalization rate was very less. Later came this balloon guide, which Gaurav has shown in his slides. It really made the job easy for embolic aspirations at the distal proximal ICS while doing a catch of the clot. Then there were aspiration catheters. We started with the bore of 4.1, went on till these were the pumps, earlier pumps. Then came to Solitaire 2, the better FR design, because Solitaire 1 had a problem at the joint. It used to get, it was getting broken at this point. They increased it so that the stent detachment was less. Then came the Solitaire Platinum. As Gaurav said, for ICS 6 and distal 4, the recanalization became better. Advantage was, Platinum was, you have a multiple markers. If you see, you have a multiple interwoven markers, as nicely seen on these images. So you can see the stent properly, where it is going, where it is landing, and you can use single stent retriever technique. You can use Solumbra. Then other companies started making stents. Stryker made this with the Trevo stent, which has a large surface area, and most of the trials earlier were done with the Trevo, like diffuse trial and all. Then other companies has these presets and all. This was an adjustable from Rapid Medical, which was fully radiopaque, controllable, and you can see this. You can bring it back, just a control here, and you can catch the clot. And you have a distal mesh, it becomes. So they say the clot entanglement was better. But Gaurav, we generally don't use this Stryker retriever in our country. It was just in the literature, it came and went off. Then came the real breakthrough in aspiration. They added to this the bore. It extended to 68. And this was a real, I think, the game changer in aspiration, the A68 catheter. The aspirations become better. More data started coming with first pass aspirations. If failed, then Solumbra. What I do is first aspiration. If it fails, then Penumbra, because if you have to add to the patient bill of 2 devices, it becomes too much. So that part, financial restraint we always have. So first aspiration, mostly it works. If it doesn't work, as Gaurav said, some clots are very nasty, they don't come out. Then you have to use different maneuvers and see what best you can do for the patient. And this was the new pump, high pressure tubing. Earlier tubing was not high pressure, the suction was not more. And this went up to 30 millimeter of mercury. And this Gaurav has already shown all these techniques. This was purely aspiration technique. You aspirate the clot and open. This was a case, post-coronary angiogram, immediately on table had a stroke. MR angio was done, shifted back to cath lab, aspirated. Because it was a soft clot post procedure, doing a vertebral angiogram. So we were able to save the patient immediately in-house during post-coronary angiogram. Please.
Sorry, can I interrupt?
No, please.
Why do we have to shift the patient to MRI? Why can't you just take it? Patient is lying on
Before
the table.
I was called, patient was already in MR.
Because like we get numerous calls from our cardiology colleague because we work side by side. And typically the sheath is in, you can just go ahead and do an angiogram. If there's a clot, you can just pull it out.
First, it took time for a cardiologist to understand that he had a stroke. So they immediately shifted to MR, and then they called me, please come to MR. So it started from MR, back to cath lab again. Now this is the new advancement, a RED 72. As Gaurav has shown in his slide, JET 71. But JET 71, Gaurav, I feel the trackability was an issue. Now they came up with this new device. So you can call it as an advancement in aspiration, this new RED 72 system. the zone of transition has increased from 16 to 20. The bore is almost 72, this bore. And trackability was better, as me and Gaurav always sometimes feel crossing in a tight carotid siphon, crossing the ophthalmic segment. If you have a anteriorly pointing ophthalmic artery, sometimes this catheters, aspiration catheter, gets stuck at the ophthalmic origin. So you need to be wary about this, don't go blind. This was a case with the posterior circulation, basilar artery. This was a concertina effect because of the sheath. Aspirated, one go. Another case, if you can see carefully, bend at the right carotid, common carotid origin. Another bend at the ICA, a 90-degree bend, and you have a right MCA occlusion. But this red navigated so well, if you can see carefully, this is the red. You can see the red has taken this curve and gone up into the MCA, and aspiration was done. So this is the betterment we feel with the aspiration nowadays. We need some device who can make my job easy and make my stress less. Rather than struggling with the device to go till the clot, my device should be saying, okay, you carry on, I am coming along with you to the clot. Now stent retriever, Gaurav has covered. This Gaurav has covered. This push and fluff technique, Gaurav has already told. Two-stage aspiration, distal aspiration and proximal aspiration. So we use two catheters for aspiration. And as Gaurav has luxury of two pumps, we use one pump and then another 50 cc syringe to aspirate. This was a massage technique with a tiger retriever. ICA thrombus. See you this. You are using a massaging, opening, closing. Whole idea is to capture the clot and to bring it out. So you need to do many things and many decisions on table, irrespective what you go with your mindset before the case. Many of times, we all experience that on table we have to change our plans. As Gaurav told, Stu-10 double solitaire technique. This is safe, like pinching the clot, Gaurav has covered. For safe technique, you have this much hardware to enter. Long sheath, catheter, guide catheter, aspiration, micro catheter for stent, micro wire. So we attached one aspiration pump with this and a syringe here. Gaurav has two pumps, so one here, one here. Gaurav, right? This was a case of revised care, like using the stent wire. Trevo has a shorter wire and that is 018 wire, whereas Preset and Aperio has a 014 wire. So what we do is, if you have a distal occlusion, proximal carotid occlusion, and MCA occlusion is there, we go with the microcatheter, place the stent at the occlusion, take out the microcatheter, use carotid stent over the same wire with monorail system, either you want to do a plasty or a stent, that you decide, do the stenting, and then take the aspiration catheter up through the stent. But one thing you have to be careful, while you are retrieving the stent retriever, it should be closed within the aspiration catheter. If it is open, then it will get stuck at the carotid stent. Then will be a disaster. Transradial, Gaurav has covered, direct puncture, Gaurav has shown. This was another case in tight arch, type 3 arch, a bite technique. You can use a balloon guide at the innominate, inflate it, then pass your aspiration catheter, then slowly you go up. You see the curve here. This one technique can be used. This is a new device for stent retriever, Ambotrap. What they claim is, you have a covering here, cage here. So the clot aspiration is much better, entanglement. Like here, you see a cage in Ambotrap. This was a case ICU occlusion, embo trap was passed, and we had a almost Tiki 2BC flow. Another case, embo trap has gone up, and we were able to aspirate. This is aspect score which Gaurav was giving so much importance, because this score has really changed the treatment in stroke. We need to save these areas. All 10, out of 10, you should have a score above 6. But now, as Gaurav has told, Japan rescue technique, they are going up to 2, the aspects, and giving patient a hope of mechanical thrombectomy. So this understanding on a plain CT scan, we take only 2 cuts, ganglionic at the thalamus level and ganglionic and subganglionic cuts we take, and we cover these areas to see how much is the ischemia and infarction. Now people are comparing with CT perfusion and aspects, and CBV is the indicator which will lead to that patient is of mechanical thrombectomy or not. This is a new kid on the block, the rapid. Using artificial intelligence by sitting at your home, getting to know about your patient on a mobile app. This software is connected to a CT, MR, as well as PACS of the hospital. Mobile app has been given to you. Immediately patients come, and it has all the, it can rule out hemorrhage. You do LVO, estimate the ischemic core volume, which is very important for us for penumbra. Estimate the penumbra, and rapid A quickly provides objective value to core and penumbra aspiration. As I said, we work on 3 factors. Penumbra should be more than 15 ml, core volume less than 70 ml, and mismatch ratio between the ischemia and infarct should be more than 1.8. This is how it works. Rapid has all these aspects inbuilt: CTA, CTP, MR, and MR perfusion also. And you have the rapid mobile apps and web apps. So everything comes to your system within 30 seconds to 3 minutes. So you come to know everything, and it is written that this patient is for MT, this patient is not for MT. So this is what the change we are seeing now. Life is easy. You are at home. You don't have to run to the console. Your all colleagues have your the app. All neurologists, all emergency people have. They know that which patient to do a triage fast, which patient will be for IV thrombolysis, which patient will be for MT. It can also depict intracerebral hemorrhage also. You can see on the app. And rapid has all the aspects score covered. It has been inbuilt into that system of artificial intelligence that sometimes it gives the better report than the human. It automatically decides how much is the aspect score on plain CT, which is the first and only neuroimaging solution available. It will rule out hemorrhage. It will tell you the aspects. Then aspects will have the clinical correlation, and you can do a CT angio. You can see these pictures. Left MCO occlusion will be seen immediately. Then you can go for CTA and CTP. CT perfusion also is covered. Benefits are clear and detailed insight that help the physician needs to know before to know that salvageable brain tissue. It supports collaboration between hospital and specialist quickly. So you can immediately tell your colleagues to open the lab, make the trolley if you are going in for MT. Like this is the example. If you see this pink area, it is a infarcted area. And see the green area, it is the penumbra area. And if you see down, it's not clear, but it is 5.5 and the volume difference is 93. So we can mismatch is more ratio. So This has been used in diffuse trial, dawn trial, extend A trial, Swift prime. Swift prime and extend 1A trial were only for up to 6 hours. Dawn and diffuse is from 6 to 16 and up to 24. And this is what the rapid does up to 6 hours Swift prime, diffuse 6 to 16, dawn 6 to 24, and 80 to 100% of these trials selected exclusively with rapid CTAP and MRI. And this was the I was talking, core up to 70, mismatch greater than 1.8, mismatch greater than equal to 15 ml. This was the case, 81-year-old male, left-sided weakness, right-sided weakness, 18 hours from onset. This generally helps in wake-up stroke. We can calculate the time when the patient was last seen well. We can take time from there, and if it is within the 24 hours, we can do a CTA, CT perfusion, and if possible, patient requires mechanical thrombectomy, you can do. So wake-up stroke, this is a boon. Earlier, we were not doing wake-up strokes much. Now we are able to do wake-up strokes. Time, the patient was well last seen. The whole ICA was occluded, and if you see, it's 142. The penumbra is more. Then we went ahead, aspirated, and did a carotid stenting on the way back. This is distal occlusion, M2. Still the penumbra is more. And it comes written patient is a candidate for MT in rapid. Went ahead, and you can use, as Gaurav said, for MIVO, you have a smaller device of 3 millimeter. Catch Mini is there from BALT. This is a wake-up stroke. Not much penumbra, volume is less. It's gone. It's 26 ml. It's more, but still we tried. But the patient outcome was not that good as it was in other patients. So why rapid has become essential in hospital settings? Streamline the stroke workflow, quantifies the volume of infarct core, quantify penumbras, pick up the diffusion negative strokes due to distal vessel occlusion, extend the window period of patient selection for treatment up to 24 hours, and increase the number of thrombolysis and thrombectomy done per month. Thank you.
Thank you very much, Arvind, for complimenting and completing the talk so nicely and beautifully. Nice cases. So now, actually, if there are any questions or comments, you are, as I told earlier repeatedly, I mean, you are free to ask anytime without hesitation, because we'll be moving from stroke to now again epilepsy, and Dr. Atmaram already been introduced. He'll be enlightening us about pharmacological treatment of epilepsy, how principles of drug use in special situations, what are the protocols for non-pharmacological treatment, status epilepticus, and refractory epilepsy. Till he has, he's setting up his laptop. I mean, all these cases look very well, very good, very nice to see, removing the clot. And I mean, last month, 1 month only, we had few cases in line, 5, 6, 7, 8 cases. We did very nicely, very beautifully, good outcome, all were happy. And the next case lands up with basilar artery occlusion. One of our colleagues, relative only, we did in morning, early morning, we opened up the artery, patient improved on the table, all were again happy. 4 hours later, patient goes down, develops a reperfusion hemorrhage. In a posterior territory, it is difficult. But again, as the experience is building up, patient deteriorated, obviously, then you are landed up with another problem. You can't give your antiplatelet, you can't give heparin, and it's a posterior circulation hemorrhage. Fortunately, as Dr. Gaurav was saying, most of these are not lethal, fatal hemorrhages. You know, just wait with time, maybe it's been now almost 8 days, the patient is out of ventilator, gradually making a recovery. So there are more hemorrhages also with these, even in a posterior circulation, stroke, they make a fair recovery. So based on these problem, one should not be, denied these procedures. That's the whole message I wanted to give. Uh, Anything further? Anybody want to ask anything about? Because this is the last talk before lunch. So over to Dr. Atmaram.
So I'm between lunch and you, so I will try to take minimum time possible. So we discussed about diagnosis of epilepsy, and now it is about treatment of epilepsy. And as you know that treatment wise epilepsy is mainly medical management. Medicines are there. But the question is which medicine, what dose, how to use, how to start, when to stop, single drug, two drug. So these are some of the important points to understand. So when we have first seizure, the question is shall we start medication or not? That was a very important question asked today. So even in first seizure, we should do the complete workup, should have detailed history, why it has happened, was there any provoking factor, should have good quality EEG and good quality MRI, and then we should think about whether to start medication or not. So in a given patient, even with first seizure, we need to start medicine if the patient is having some deficits. EEG, good quality is showing clear-cut epileptiform discharges. A person who is at a high risk of seizure-related complications, like a person who needs to work in some circumstances where any seizure can be life-threatening. So even in with single seizure, we may think of starting medication. So which medicine and how to start the medicine? Ideally, any patient with single seizure, we should think of single medicine, monotherapy. The medication will be depending upon the type of seizure, type of epilepsy syndrome. We discuss about this comorbidity in our diagnosis presentation, and then we'll talk about the treatment here. Suppose one drug fails, then whether to add another one or to switch over. So these are some of the questions we'll discuss. So when we start medicine, first thing is what type of seizure we are dealing with, what type of syndrome we are dealing with, what efficacy wise which drug is the best medicine. Cost is a very, very important factor when we start medicines, because as you know, a person may not take a costly medicine for a long period, and that may result in relapse of seizure. So depending upon cost, we may have to choose a drug which may not be the best drug for that particular epilepsy, but rather than taking nothing, one particular cheaper drug may have some good improvement. So at least cost wise, 2-3 medicines are very cheap. One is phenytoin, then carbamazepine, and phenobarbital. So each costs roughly 1 to 2 rupees to maximum 5 rupees a day. Then pharmacokinetic profile is very important, because drug to drug interactions, especially in patient in elderly who are otherwise on multiple medications. So if you give enzyme inducing drug, that can have detrimental things. Patients who are transplant patient on immunomodulators, those patients we should not give enzyme inducing drugs. Cancer patients on chemotherapy guidance. So these are the patients where slight modification in the drug can create problem for the primary disease. Then adverse effect wise, we should know each common side effect of each and every drug, so that we can modify if that is troubling the patient. We do have a big list of medicines nowadays, at least last 20-30 years, so many newer drugs have come. Still phenobarbital, phenytoin, carbamazepine, sodium valproate, these are still being used quite commonly. So if we see this graph, phenobarbital has covered more than 100 years, phenytoin is reaching to 100 years, then other drugs like carbamazepine, valproate, these came. In last 20-30 years, so many newer drugs have come. So we'll try to discuss each and every drug in a simpler way, whatever is possible in that given time. So drugs are basically classified depend upon the type of mechanism of action. Most of the drugs are sodium channel drugs. Lacosamide is another sodium channel which acts on a slow sodium channel, different from other sodium channel. Other drugs works on GABA. Some drugs work on this AMPA receptor, which is not here. This perampanel is a newer drug. So these are some of the mechanism of actions. So for focal seizure, if somebody is having clear-cut focal seizure, somebody is having NCC, post-head injury, post-brain surgery, brain tumor, so those patients are basically having focal epilepsy, even if their presentation is GTCS, because we do have a clear-cut focal pathology. And those patients we should treat on the line of focal epilepsy rather than on the line of generalized epilepsy. Drug of choice wise, carbamazepine, oxcarbazepine, lamotrigine, levetiracetam are the drug of choice for focal epilepsy. But other drugs like clobazam is a very good add-on. In refractory epilepsies, lacosamide is a newer drug for focal epilepsy. And even in emergency, lacosamide injectable is available and you can give, especially if it is a focal epilepsy. If we have clear-cut juvenile myoclonic epilepsy, the video which I showed, or absence epilepsies, those cases comes under the category of idiopathic generalized epilepsies, and the drug of choice is sodium valproate. The problem with sodium valproate is female of childbearing age group. We should definitely avoid sodium valproate in that age group. We can give only and only if other drugs are not working. We should not give it as a first line of medicine. For any childbearing age group female, sodium valproate should be avoided. Other options are levetiracetam, lamotrigine, then we do have zonisamide, topiramate, and even newer drug like perampanel can be given in idiopathic generalized epilepsies. So key point to choose the first drug is again same. We should avoid certain drugs like in juvenile myoclonic epilepsy. If we give sodium channel drug like carbamazepine and phenytoin, they can in fact worsen the myoclonic drugs, though they may control generalized tonic-clonic seizures. So it at times happen that in patient whom we suspect JME and they are very well controlled on carbamazepine, as a new epilepsy trained fellow, you start thinking why to give carbamazepine, let's try valproate. So the dictum is never change the winning horse. The patient is doing well, why to change? So it's possible that that particular drug is doing wonder for that particular patient, why to change? So similarly, absence drug can be worsened by sodium channel drugs. If we are not able to diagnose whether it is a focal epilepsy or generalized epilepsy, then we can definitely choose some broad spectrum drugs. Among the broad spectrum drugs, nowadays the commonest one being used is levetiracetam. The newer type is braviracetam. Otherwise, you can use clobazam, lamotrigine, sodium valproate, topiramate, zonisamide. These are some of the broad spectrum drugs. The narrow spectrum drugs are mainly sodium channel drugs and mainly used in focal epilepsies, except ethosuximide, which is the drug of choice for absence epilepsy, and nowadays it is easily available in India. So childhood absence epilepsy, we can give this ethosuximide. So narrow spectrum drugs are effective in focal epilepsy but can worsen myoclonic drugs, while broad spectrum can be used in unclassified epilepsies. So start with single drug, smaller dose, because like carbamazepine, if you give higher dose on day 1 and patient is allergic, you can have Stevens-Johnson syndrome. Lamotrigine, again same thing can happen. So some of the drugs needs to be titrated very, very slowly. Some drugs you can rapidly titrate like levetiracetam. Even braviracetam, they say that there is no need to titrate. So these are, if you are starting with a smaller drug of a smaller dose, then you can for the time being add drugs like clobazam temporarily for few days. Then we need to discuss, especially in female, about the issue of teratogenicity and contraceptions. We have a 4-5 slides on women with epilepsy, then we'll discuss about that. And compliance should be stressed from very day one. When you are starting medication, you should give extra time to counsel the patient about drug compliance. So, disease oriented versus patient oriented. So, what is the difference? Like in a focal, suppose the patient is having juvenile myoclonic epilepsy, the drug of choice is sodium valproate. So, disease oriented is sodium valproate, but the patient is very obese. So, it becomes now patient oriented, because sodium valproate will increase the weight further. Then you give drug which reduce the weight, like topiramate or jonisavir. These are some of the drugs which help in reducing weight. So, that patient oriented medications are more important. Among the comorbidities that we discussed, like a patient who is taking medicines for epilepsy and is having frequent headache like migraine, there are two options. One is give two different drugs, one for migraine, one for epilepsy. Other is give a drug which works in both, like topiramate, sodium valproate. For anxiety and depression, we should avoid levetiracetam, because that can worsen anxiety, irritability, psychosis, mood, even speech issues can worsen with these drugs. If there is a mood disorder, we want to give mood stabilizer, then these four drugs are very good for mood stabilization also: carbamazepine, lamotrigine, valproate. Sleep, suppose is getting disturbed, you can give clobazam, which helps in both. Cognitive impairment wise, topiramate is one of the worst drug. Then zonisamide can also have similar effect, but you can give newer drugs. Obesity, we discussed about it. And then hyperactivity, then we can avoid this benzodiazepines. If the patient is having significant arrhythmia, heart blocks, then certain sodium channels can be avoided. Suppose that first drug is not working, then what should we think of? Almost 1/3 of the patients who are not responding to first drug are actually having non-epileptic events. Nowadays, everybody is having mobile with video recording. So, ask the family to record the events. So, seeing the video helps many a times in making a proper diagnosis, whether it was a true seizure or a pseudo seizure. Some patient may have combination which is very, very difficult to treat. So, the saying is that it's easy to treat epilepsy, difficult to treat non-epileptic events, and very, very difficult to treat the combination. So, pseudo refractoriness can happen in patient whom we are not giving the best drug. Like suppose we have tried lamotrigine, levetiracetam, but we haven't tried sodium valproate in primary generalized epilepsy, then we can say it was practically a pseudo refractoriness. Triggering factors definitely should be taken care of. So, if it has failed, then you can check for compliance. Compliance is another important part. Many times, if we don't take detailed history, they will not tell that the patient has missed medicine. So, if patient is well controlled and comes after 6 months, 1 year and says that I am having a seizure, just first ask how many days you have not taken medicine. So, most of the time they will say that yes, I have missed for so many days. Then if compliance is good or you doubt about compliance, you can check drug levels or you can change the medication. So, when we change medicine, so one option is like changing the medicine, or other option can be kind of just slowly first keep the first drug, start the newer drug, and once the newer drug reaches to a significant level, then only taper the first drug. So, this is a safer approach in terms of patients who are having frequent seizures. Adding another drug when you feel that first drug has worked a bit, so then you can just add the second drug. At times, suppose you feel that second drug has worked better than first drug, you take second drug and then can add the third drug. So, when we talk about addition of medicines, it becomes polytherapy. Polytherapy is very, very common in epilepsy, but it's very dangerous. The reason being is many drugs have interaction. So, you don't know which drug is working, which is not working, which drug is producing side effect, which is not working. So, when we are adding a drug with another drug, try to avoid the same mechanism of action drug. So, it's not useful to add carbamazepine with phenytoin because both have almost same mechanism of action. So, adding a sodium channel with sodium channel drug which is not a good choice, except lacosamide, which can be added because it has a different sodium channel mechanism. Then adding broad spectrum drug can be useful in some cases, but best is adding two different mechanism of action, like sodium channel with GABA. You can add clobazam with carbamazepine, phenobarbital with phenytoin. So these are some of the combinations which are there for many years. So good combination wise, sodium valproate with ethosuximide, very good for abscesses. Sodium valproate with lamotrigine. Suppose somebody is getting lot of side effect with sodium valproate, but is well controlled. You reduce the dose of sodium valproate, add slight low dose of lamotrigine. This combination patient may tolerate better, may not have many of side effects. Lamotrigine with topiramate, carbamazepine with clobazam is a very good combination for focal epilepsy. Then phenytoin and phenobarbital combination was being used for many years in many patients very successfully. So coming to individual drug, so when we talk about individual drug, there are certain drugs which we need to discuss, and I'll take maybe another 10 minutes or so. Okay, thank you. So phenobarbital, as you know, is the oldest drug, and it's being used especially in neonates because this is the drug which has had least side effect in neonates, and very well experience is there for so many years. It can be used in infancy. It can be used in unclassified epilepsy, especially when there are financial issues. The advantage is it's available in tablet form, syrup form, and injection form. So that is the best advantage with phenobarbital. Phenytoin again is available in all the form, can be used in any type of epilepsy, and it was the best. It was the drug which was being used left and right almost 10-20 years back. Now slowly levetiracetam is taking over. Carbamazepine, oxcarbazepine, eslicarbazepine, they are very good drugs for focal epilepsy. Only thing is these drugs cause hyponatremia. Especially oxcarbazepine is more likely to have hyponatremia. So if you are treating elderly, don't give oxcarbazepine, even for trigeminal neuralgia or anything, because hyponatremia can be very life-threatening. Sodium valproate, as we discussed, is a very good drug, can be given in any type of epilepsy, but there are issues, especially for female. Weight gain is another issue. It's available in, again, tablet, syrup, and injectable form. Clobazam is being used in India for many years. It's available in US for recently only. Very good drug as add-on for refractory epilepsy, for pediatric epilepsies. It works even in long term. It's not that it's a short term medication. You can give for 5-10 years easily without any issues. Good drug for catamenial epilepsies, you give 2-3 days prior to menstruation and continue 4-5 days later. Good drug for focal reflex epilepsy, like a case which I showed of eating epilepsy. You ask the patient to clobazam half an hour before taking meal, so then it works well. Other anxiety and sleep also it helps, but we should avoid in elderly because of sedation and other side effect. Levetiracetam, as we discussed, is being used left and right nowadays because practically it is active against all type of seizures, can be used in hepatic patients, no drug to drug interaction, can be given injectable in emergency, available in all forms. Issue is behavioral. So about 10% of the patient with levetiracetam can have very severe behavioral issues, irritability, psychosis, aggression. So those patients we should definitely change it. Lamotrigine is a very good drug because there are no major side effects. It helps in mood stabilization. It can be used in practically all type of epilepsies. Good combination with sodium valproate. Disadvantages are that drug allergy can happen, so we need to start very slowly. Lacosamide is available in injectable form and now being used for status in injectable form, in especially in neurosurgery ICUs or neuro ICUs where post-stroke patient, post-surgery patient, they are likely to have focal seizures, so you can just give injectables. Perampanel is probably the last or second last drug which has come in India. Very good drug for focal epilepsies, even in status epilepticus, especially refractory status epilepticus. You can give a tablet of 4 mg, 8 mg, and it has worked in many cases. Topiramate is useful for obese patients, migraine patients, but problem is of renal stone. Zonisamide almost like topiramate, but safety wise better than topiramate, and again good for obese patients. Breveracetam is the latest drug came in India, and it's slowly replacing levetiracetam in many cases. Behavior side effects are less, but disadvantage is it can have some drug interaction. Levetiracetam has no drug interaction. Levetiracetam is having a clear safety profile from teratogenicity point of view. Breveracetam we don't have a data. So breveracetam as of today will not replace completely levetiracetam. Dose wise, as you know that carbamazepine 100 to 200 of carbamazepine is 1.5 times of carbamazepine. The full dose you can give up to 2400, but we have seen that once you reach a certain level, beyond that ceiling effect is there. So if you are giving carbamazepine 400, 600, maximum 800, it works. Beyond that, not much of their tolerability side effects are quite significant. So better to keep on the slightly lesser than very maximum dose in many cases, and most of the 80-90% patient will have good improvement even with 80% of the maximum dose or 60-70% of maximum dose. Side effect profile, you should know that especially common side effects like drug allergy, Stevens-Johnson syndromes can happen, renal stone can happen, topiramate rarely can cause acute angle glaucoma, which can be dangerous for the patient. So these are some of the side effects we should know. So ideal drug should be a broad drug, spectrum drug, effective for all type of seizures, very high efficacy, safe, should not have any teratogenicity, no drug interaction, but unfortunately we don't have any such ideal drug as of today. So we have discussed already about this, I'll skip that. Just few points about women with epilepsy, because a very important topic and sir asked to add this particular topic. So when we talk about female and epilepsy, there are issues about hormones, catamenial epilepsies. Marriage issue is a very big issue, especially in India, because a female with epilepsy getting married is very challenging. Acceptance issues are there, disclosure or not to disclosure, lot of issues are there. Then use of contraceptives and pregnancy. So most of the time a female, when come about pregnancy planning, they will ask what to do, whether to give medicine or not to give, when to plan pregnancy. So all these important questions are there. So what will be the effect if I take anti-seizure medicine on my baby? What will happen during delivery and breastfeeding? So in terms of pregnancy, epilepsy is not a contraindication at all. More than 90% of the female with epilepsy with medicines will have absolutely normal pregnancy. So we should not discourage from pregnancy point of view. So shall we continue medicine or not? If the female has not yet planned pregnancy, so we can taper and stop medicine, but give at least 6 months before planning pregnancy, because the risk of seizure recurrence is high in initial 6 months. So, but if there are seizures ongoing, then definitely we'll have to continue medicine. Seizures may worsen in some of the cases, may remain stable, but in majority of the cases it remains almost same. So 96% of the patient can have normal children, though there are chances of higher abortion or preterm birth and fetal malformation, but the risk is less than 4%. So when there is an epilepsy, clear it, check whether the patient need medicine or not. If possible, you can change medicine if the patient has come before becoming pregnant. Give folic acid and then follow up. Screen for malformation by doing this serum quadruple test, and ultrasound, especially level 2 or level 3 ultrasound should be done in all patients with epilepsy and pregnancy, so that we can detect if there is any malformations. Breastfeeding should be encouraged in a female with epilepsy. So the reason is, even if the seizure medicine is being secreted in the breast milk, the side effects are less than benefit of the breastfeeding. So this is how you do. You can check for malformations at around 20 weeks. Folic acid continues, give vitamin K, then breastfeeding and contraceptives. Among the contraceptives, hormonal contraceptives, OCPs, if possible, should be avoided with certain drugs which have enzyme induction. In elderly, just one slide that the risk of misdiagnosis is more because syncope is more likely than seizure. So take history in detail. Patients are usually on many medications because of cardiac issues and other issues. So when you start medicine, don't give enzyme-inducing drugs like carbamazepine, phenytoin, phenobarbital. These drugs have a lot of drug interaction. So for those patients, triple L, lamotrigine, lacosamide, levetiracetam, these are some of the options you can think of. And in elderly, the duration of treatment, actually speaking, should be lifelong because any seizure recurrence can be life-threatening. If we are not able to control with medicine, then surgical options, which I'll cover in last talk. And I'll just going into let me see, status epilepticus, 2-3 slides are there. So in status epilepticus, previous definition was 30 minutes of seizures. Nowadays, any seizure for more than 5 minutes, GTCS should be taken as status epilepticus. If any GTCS is going more than 5 minutes, consider it as status and treat aggressively. There are various types of status epilepticus, psychogenic status, focal status, myoclonic status. Then comes refractory status. If we are giving two medicine, one is benzodiazepine and other is like phenytoin, phenobarbital, sodium valproate, levetiracetam, and the patient is still seizing, then it becomes refractory status epilepticus. Super refractory status epilepticus, the patient is seizing even after 24 hours of sedation. We have given anesthetic agents. We reduce anesthetic agent, patient start getting seizure, or on an anesthetic agent, patient gets seizure, then it becomes super refractory status epilepticus. There are certain other terms like prolonged super refractory status epilepticus, prolonged refractory status epilepticus. So approach is that initial 5 to 10 minutes are very, very important. Then 10 to 30 minutes are for established seizure. Then comes the super refractory status. So how to approach? Investigations, routine blood tests. If patient is taking any medicine, then drug level can be sent. In certain cases, these investigations are required. Baseline ABC is important. Then give thiamine if you suspect that patient is of alcoholic patient. Otherwise, give lorazepam, midazolam, and or diazepam, whichever is available. And you can repeat it if the seizures are not controlled. Drug-wise, you can give phenytoin. Phospheniton is better than phenytoin because the seepage, if it happens subcutaneously, will not cause gangrene, will not cause purple hand syndrome. Arrhythmias are less with phospheniton. Hypotension is less. Then comes phenobarbital, levetiracetam. The newer drugs are brivaracetam, which is available, and lacosamide. Then if the still seizures are coming, then you need to intubate, you need to use anesthetic agents like midazolam, thiopentone, propofol. And among the newer anesthetic agent is ketamine, which is very, very useful, especially in super refractory status. We should give ketamine on priority, especially in patients who are having hypotension, because it helps in stabilizing BP also. So other options for super refractory status are like magnesium, hypothermia, immunomodulators like methylprednisolone, immunoglobulins, plasma exchange has also been done, rituximab has been given. Ketogenic diet is another diet which can be given, especially in super refractory epilepsy or in pediatric epilepsies where they are not responding to normal medications. So ketogenic diet, the advantage is that in some of the patients they have excellent response in refractory epilepsy, and the formulation is basically more of fat diet than carbohydrates. So carbohydrates almost zero, then protein and fat are given. Then certain cases even emergency surgeries have been done. Thank you.
So before we go to lunch, if there are any questions or comments, very nicely covered this whole part. So other than surgery, most of the things are covered. I have a question, like for pediatric patients, I mean, those who do not have any history of birth hypoxia or anything, like, I mean, what workup you will advise, metabolic workup, especially in pediatric population? And it is advisable to add this pyridoxine in all these patients if you don't have any specific etiology.
So one disclosure is I am actually an adult neurologist, but still if it is a very, very small kid, some infant getting frequent seizures, not controlled with medication, neonate getting frequent seizures, pyridoxine trial is well worth trying. Pyridoxine should be tried. Then metabolic workup wise, we do send urine for metabolic screening. Nowadays even blood tests, genetic tests are available. So any patient who is not responding, especially in pediatric population, complete workup of metabolic and genetic should be done. So
12 weeks in normally.
So what they say that there is no harm in continuing folic acid throughout pregnancy.
Okay.
It
In
can
normal
easily-
cases also?
It can be given safely.
Okay.
Yeah.
Thank you.
Ideally speaking, the folic acid should be started prior to planning pregnancy, at least 3 months before pregnancy.
Thank you, sir.
Thank you, sir. Yes, sir. Weight gain. Yes, sir. So there are trials that valproate and topiramate has worked very well. Disadvantage wise, there are two. One is ammonia can worsen because topiramate and valproate both can worsen ammonia. Second is a bit of cognitive slowness can happen despite on valproate. And for female, again, that is an issue. Yes, yes. So clobazam can be combined with any drug, whether it is sodium valproate, carbamazepine, oxazepine, levetiracetam, any drug you can combine except phenobarbital, because both are benzodiazepines, so there is no use of combining both. Yes, sir. Very, very important question, $1 million question, but the straightforward answer is not there, because it depends upon type of epilepsy, it depends upon what type of patient you are dealing with. A patient who is otherwise normal, whose EEG is normal, MRI is normal, you can think of stopping medicine maybe after 2-3 years. Always let the patient stop medicine rather than you provoking the patient to stop medicine. Because that happens. Let them buy the kind of your option.
As a master of epilepsy, any personal experience with keto diet, because keto diet was introduced 100 years back only for the treatment of epilepsy then?
One disclosure, I am not a master, I am still learning.
Okay.
And second, ketogenic diet, yes, it works. It works very well in selected cases.
I said personal experience.
Yes, I have patients, but I am not practicing pediatric epilepsies. With my pediatric epileptologist, we have treated patients with ketogenic diet.
Dr. Atulab can share the answer. Dr. Atulab, hello.
Dr. Atulab.
Yeah, I think you can share the answer also.
Actually, probably I can talk about diet role in stroke, not in epilepsy for sure.
No, there are many centers, they are running successful ketogenic diet programs, especially AIMS. Even in Lady Harding, they have very good ketogenic diet. Dr. Swashni Sharma is one of the pioneer working on ketogenic diet in epilepsy in pediatric patients.
It's very difficult to tolerate ketogenic diet. I mean, that's what I hear from pediatric neurologists.
Yeah.
I mean,
it should be done under
Definitely
supervision.
it is very tough for the person also, but then it was modified, say after 50 or 60 years, for epilepsy to be a cyclical ketogenic diet. Means for 4 to 5 days you give ketogenic diet, for another 2-3 days patient will take a normal diet. This is known as cyclical ketogenic diet. It was a modified.
Comments on that?
So there are a lot of modifications happening in ketogenic diet. It is what 1:5 previously, then 1:4, 1:3. So ratios are also changing. So now they are a bit more liberal, because otherwise if you are too strict, the compliance will be poor.
I think if there are no further queries or comment, let's have some glucose and then come back.
Yeah, not keto diet.
Not keto diet.